Rocking along and getting started this morning.
You what?
So rocking along and getting started this morning. I've got a couple concepts I want to hit before we get started.
Glenn says he's on his way. He want to know how many humans were here in the class. Just
how many humans?
Yeah.
There.
Are you guys expecting more than?
I think we're expecting 2 or 3 more to show up this morning. Okay. So I don't know.
All right.
Right now, there's only 3 of us in here. So we talked about the oxyhemoglobin dissociation curve on Friday. Y'all weren't here, so I mentioned it briefly. We're talking about airway anatomy or complex airway stuff, and this is always one of those concepts that kind of messes with people a little bit, and it's one of those concepts that they like to test, and it's always one of those weird things. And I wanted to try to break it down as simple as I could for our application. But when you're looking at the the hemoglobin and the saturation of the hemoglobin, all this curve is describes the relationship between PaO2 and the amount of hemoglobin that's actually being saturated in the body. So if a patient has a PaO2 or arterial concentration of oxygen of 90 to 100, the hemoglobin is said to be at 100% saturation. So if there's an increase above that 100%, we're increasing our PaO2 to 600. Does it do us any good? No. And this is what we're more recently talking about free radicals developing. And once the hemoglobin is saturated, it can't transport any more oxygen. It is at its maximum affinity. So this curve describes things that actually affect the affinity for oxygen, or of the hemoglobin for oxygen. And we describe that in a left shift or a right shift based on this graph. A left shift would be something that actually increases the affinity for oxygen. So a patient is hypothermic. They've been submerged underwater. This is one of the reasons we say we work patients till they're warm and dead, because when you're hypothermic, your body has an increased affinity for hemoglobin, so it can, I'm just going to use dull numbers. If a hemoglobin molecule is able to saturate 4 oxygens on it, it can saturate 5. It's going to it's able to hold more oxygen because of that increased affinity over other inert molecules, over carbon dioxide, over nitrogen, because they do transport other molecules. But hemoglobin has the greatest affinity for oxygen. That's what we're looking for, is oxyhemoglobin, and then of course carbon monoxide on the other side. Decrease in hydrogen ion concentration. So hydrogen ion patients with metabolic alkalosis or in alkalosis, they're going to have an increased affinity for oxygen, and increase in cardiac output. They're going to have increased affinity for. Increase in carbon monoxide. So if a patient has carbon monoxide, they're going to have an increased affinity for their hemoglobin to be saturated. It's not necessarily to be oxygen. So if we ever encounter a situation where, all right, I'm going to just break it down in simple. If you encounter a test question where they're describing a patient that's in metabolic alkalosis, and they're asking if the patient's hemoglobin has a greater or a less of affinity, it would be a greater affinity for an alkalotic patient. and that's a left shift on the diagram. So left, greater affinity, and exact opposite on the right. Right shift is have a reduced affinity. This could be a patient that's septic. They have an increased body temperature. They have an increase in hydrogen ions, so they're acidotic. And then we had a question the other day about 2,3-DPG, and I'll kind of talk about that for a second too. Just send a message to log in. The reason this is important is when we increase, or when the affinity for oxygen decreases, that means we have to have more oxygen to perfuse the same amount of tissue. So if on this curve, see down here we're at 100%. Here, if you have a shift to the right, it takes an increasing amount of oxygen saturation to hit that same 100%, or 100 on your PaO2. Generally, we don't get PaO2 to 100, usually somewhere that 80 to 95 range. But all we're saying is we have to have more oxygen, hemoglobin saturated, to reach the same amount of oxygen concentration in the blood. So some other things that could affect this would be an increase in altitude. So if we're increasing in altitude, we're going to see a shift to the right. This is why we commonly, and I say altitude, I don't mean like we're going up 2 stories, but if we're in a aircraft from, here, nearly sea level, I mean, I don't know what altitude we're at, but we're not much above sea level, and we're traveling, to Denver. We have a change in our oxygen concentrations. This is why we pressurize aircraft. For one of the reasons, among a few others, but patients who have shunting physiologies already, who are already compromised for their oxygen delivery, they'll need more oxygen to maintain the same amount of oxygen saturation and oxygen delivery at a higher altitude than they will here. There's a formula for that, but we don't get into that in here. Just basically explaining the fact that you'll need more oxygen for the higher altitude you go. Same concept of a patient is having a diving emergency. They've been 100 feet underwater. They can rapid descent. At that point, we've changed the pressure, right? So the pressure at 100 feet below water, we're at 99 feet below water. It's you're at 4 atmospheres at that point. So when you're at a lower atmosphere, we have an increased pressure on us, right? So we have an increased pressure, actually have a greater affinity for oxygen at that lower atmosphere. The oxygen molecules are smaller, and it excites the whole nitrogen narcosis point, but bringing a patient to a higher concentrate, a higher atmosphere, or I guess a lower atmosphere, bringing them back to normal atmospheric pressure. We see that shift to the right for not exactly the same reasons, but the same conceptual reason. So we can't necessarily fix that with high flow oxygen. We need a hyperbaric chamber to compress the patient back, keep the pressure back down in order to deliver that oxygen. 2,3-DPG was a concept we talked, I was asked a question about on Friday. Is there something we can do to actually measure that? And 2,3-DPG or BPG is biphosphate glycerate or diphosphate glycerate, whatever. It goes by both names. And is there something we can do to measure in the field? Not really. It is this is someone who's, or this is a byproduct of red blood cell metabolism and red blood cell destruction. So when red blood cells are differentiated in the bone, basically, this is where DPG is, 2,3 DPG is created. And a increase in 2,3 DPG is the degradation of those red blood cells. So if we have more red blood cells being degraded, we're losing oxygen carrying capacity. We're losing hemoglobin. Same concept goes if your patient's bleeding. If they're bleeding out, we have less oxygen carrying capacity. So if the patient has blood loss, they're going to have a shift to the right. Just like if they have circulatory overload, they're going to have a shift to the left. If they have, circulatory overload, if they have too much blood on board, they've been overloaded with resuscitative, like packed red cells, that decrease 2,3 DPG because of the increased amount of hemoglobin is going to have to decrease 2,3 DPG. So long story short, no, they can't. No, we can't measure it. Short of the closest thing we could get is doing an ISTAT and measuring an H&H. That would be the closest thing we could extrapolate a 2,3 DPG, but it's a lab test, so it's not really all that important for what we're going to do. And that little rant was to answer some questions that I didn't answer the other day. I'm sorry. And picking up this morning, cardiovascular system. I'm not going to insult your intelligence in some aspects. We'll walk through a cardiovascular review to some extent. The reason we review is because everything comes back to, how it works, right? Everything we do and how we treat patients, how we look at signs and symptoms comes back to making sure we know how the system is developed. We all know the heart pumps the blood vessels allow it to circulate through the body. The function of the cardiovascular system as a whole is to deliver oxygen and nutrients and remove waste products, carbon dioxide from the tissues. You know where the heart is, the apex is pointed down toward the left hip. So it's generally about the size of your fist in the thorax between the lungs. Coverings. Visceral pericardium is the visceral layer. Think of it's a layer affixed to the heart itself, and the parietal pericardium is the outside layer of the pericardial sac. There's a thin serous fluid membrane in between these that allows the heart to move and float in there. What kind of condition is going on if we get an increase in fluid in that pericardium? Yeah, we can have tamponade. We can have, a light version would be, or a little bit of extra fluid would be pericardial effusion. A larger amount would be pericardial tamponade, because that's where we're actually impairing the actual contraction or actually the expansion of the ventricles. So if we can't expand, we're reducing the amount of blood volume we're ejecting. And we see that's classic signs we see with tamponade. Yeah, Beck's triad, we see JVD, we also see narrowing pulse pressures. And trivial question, not something you'll be tested on, but again, my goal is not to cater anything to a test. It's trivial. So what is the #1 cause of pericardial effusion or tamponade? That's a good one. It probably a little bit broader, but I like the outside the box thinking. Everyone's first guess is trauma, usually. And like I said the other day, trauma, we used to be very trauma focused, and now we just feel sick people all day, every day, right? That's, people get in this to go work the the multi-vehicle collisions, and that's how EMS got its start. But less than 10% of our calls now are trauma, and less than 10% of those are like really, really bad trauma. Maybe it's higher than 10% for the bad trauma, but anyways, where I'm going with that is actually metastatic cancer is the number one cause. Both lung, brain, esophageal, pericardial cancer. So that's a very common finding in these patients. We've put a lot of windows in for these patients. And then trauma, I was going to say pericarditis is another one, but I kind of relate that because a lot of pericarditis cases come back to cancer. Oh, well, there we go. Look at that. So the heart wall has three separate layers. The epicardium, the outermost layer. The myocardium is the thick muscular layer. That's what's doing all the work. And the endocardium is the endothelial layer. Generally, the endocardium is less than two cells thick. It's usually about one cell thick on the endothelial tissue. I'm not going to beat to death knowing coronary artery anatomy. I will say you need to know EKGs, 12 lead and 15 lead EKGs, and what areas of the heart that are most likely affected, like which coronary arteries are being affected by changes in EKG elevation. I didn't put that in here, but I just thought, I mean, you need to know that anyways, but come back to it.
Your PowerPoint can be accessible online.
The video will.
Okay.
I hadn't thought about the PowerPoints themselves. I've been a little hinky about that because somebody took a lecture I put a lot of work into and stole it. So I'm not saying anybody would do that. So I'm a little hinky about giving the actual PowerPoints out too. So the video will be available. I'll see about putting notes on there, like putting a notes page together. But I made that mistake and they stole all my stuff.
This may be a dumb question, but where's the video?
So Glenn has a private YouTube channel that he has to he sends you a link to, and every video will be uploaded from there. I don't know if the ones from yesterday are uploaded. I just got Saturdays converted like late Sunday night because I messed that up. So, but they're all set to be up there. So once you have the link, it should just populate all those videos. You have to have the link to get into it though. You can't just find it. So the left and right. Ricky's Reggie. Oh, one second. I gotta pause recording because I had sorry. So left and right. On the left and right side act as separate pumps. The atria receives blood from the right atria, or the atria receives blood from either the systemic circulation or the pulmonary circulation. The ventricles discharge blood into either the pulmonary circulation or systemic circulation. If I refer to left and right-sided heart, left and right-sided pump, or high pressure, low pressure, if I'm referring to a high pressure side, I'm referring to the left side of the heart. If I refer to low pressure side, I'm referring to the right side of the heart, whether it be the atria or the ventricles, or whether it be the atria and the ventricles on the right side as low pressure, and left side, atria and ventricles for high pressure. I will use left-sided or right-sided high pressure and low pressure interchangeably. Blood circulation, not going to insult your intelligence, much more than, say, just pulmonary arteries. The only place that unoxygenated blood goes through arteries, and then the pulmonary veins, oxygenated blood coming back from the lungs. I will say when we'll talk about hemodynamics in a little while, and this is probably the best way I can illustrate that. When we are measuring a pulmonary capillary wedge pressure, we have a catheter, and this is not to scale, obviously. We have the catheter, balloon catheter here, and we're wedging this in here. We are wedging this pressure here so that we get a measurement of the pressure in the left atrium. So that's what we're doing with pulmonary capillary wedge pressure. We're actually measuring the pressure coming into the left atrium. We'll talk about that a little later before you guys leave. Heart valves allow blood to flow in only one direction. There's 4 valves. The AV valves between the atrium and the ventricle. The semilunar valves are between the ventricle and the arteries. If you have ever been confused about which valves do what, just think your semilunar or your aortic and your pulmonic. Aortic's going to the body, your pulmonic's going to the lungs. Your bicuspid on the left, think of bicuspid, strong, left side of the heart, but bicuspid. Y'all can't see me, I'm flexing. Tricuspid on the right, so I just say, I try to break it down to simple things. I don't care if you, there's not going to be a heart diagram that you have to know how to diagram which is bicuspid, which is tricuspid. The valves open as blood's pumped through. They're held in place by the chordae tendineae, and when pressure drops, the pressure starts to drop, the valves close, and blood clears out. The noise that you hear when your oscillating heart comes, your lub-dub, your valve. We always say it's a valve closure. You're not hearing the valve closure. You're actually hearing the blood hitting the valve after it closes. So we're not actually the valve doesn't make a noise itself. The flow through of the blood makes the noise. I'm not gonna beat to death operation of the heart valves. A few great vessels. What we're talking about is the aorta, the pulmonary arteries, the vena cava, and the pulmonary veins. Those are the trunk of the great vessels versus the coronary arteries. Coronary arteries, has its own circulatory system. Know your coronary arteries. When do the coronary arteries get perfused? During diastole. So when the heart is relaxing, it's when we're perfusing those. So the conduction system, this is part I thought was cool. This is where the smart board came in handy yesterday, and I made some notes yesterday that will help us illustrate this. The heart has its own conduction system. The muscle cells contract without nerve impulses in a regular, continuous way. That is the term. Let me ask you, what's the term? Heart starts on A. Automaticity, yeah. So automaticity, the SA nodes are primary pacemaker, the AV node, our secondary pacemaker, and then you have AV bundles, Purkinje fibers, etc. The atria relax and contract, or atria contract simultaneously, then they relax, the ventricles contract. We all know systole is contraction, diastole is relaxation, and we talked about it, and I mentioned it yesterday. The formula for MAP is, this is one of those. One of those formulas you need to know, you need to be able to calculate is 2 times the diastolic plus the systolic divided by 3. And I break it down to the simplest cycle. Why is it 2 times the diastolic? I don't know if I talked about this with y'all here yesterday.
It's just the heart spins.
Yes, yeah. So heart spins twice as long in diastole. So we have three segments. two of it being the time frame being diastole, one of it being systole. So that's where we have 2 diastole, systole divided by 3. So formulas, that would be one to always remember. So the contractions, and contractions initiated by the SA node, and I put these little myocytes up here because it doesn't, we always talk about the, the conduction system of the heart, that we have the SA node and it fires an impulse and it goes this way down to the AV node, and then we go down our nodal pathways with bundle hiss that way. That's our, we think we don't do a very good job of explaining this is not exactly how it works. We think we describe it as it's an instant impulse, right? It's quick. It is quick, but the cells in the heart have what we call gap junctions. And the gap junctions allow for them to depolarize rapid fire. And it actually looks a lot like this. Think of these as individual myocytes. And as the first SA node indicates an impulse, and those first cells start to depolarize, the gap junctions allows that next cell to cause that next cell to depolarize, and then the next cell to depolarize, and the next cell to depolarize, and then the next cell, and so on. So it's not exactly a straight impulse. It's not an impulse along a nerve, an axon like we think of other nerve impulses, but it just goes from cell to cell to cell. The one's supposed to be blank, the last one, but moving along those junctions, and eventually, it's not exactly an even process, and everyone's a little bit different. So this cell's depolarized here. Well, this one over here might not, but the next time this one might depolarize, and then over here this one depolarized, and then we're just moving those as we move along. So I like to just illustrate that because we think of it as the electrical conduction system being a nerve fiber that goes through there, and it's not. It doesn't really work that way. It's a series of myocytes that have that automaticity to actually depolarize and cause the next one to depolarize as they go down like a tandem train, and just a rolling depolarization. That being said, if we have a big infarct, an interior MI, and you have infarcted tissue right here, or let's make it a little bit bigger, right here. What do you think is going to happen to these cells here? Yeah, it's going to have a delayed conduction. So when I'm looking at my EKG tracing, a normal EKG tracing, and don't make fun of my artwork, but if these cells have to go around this necrosed area, eventually it will depolarize it. Eventually it will expand and it'll do that. But this is where you start to see a widening of the QRS complex because the electrical conduction is taking longer because it's got a bunch of dead cells in the middle. And so those dead cells, it just takes longer because it takes more or a less direct route to depolarize here and here and here and here and here and here, and then continue on its path to depolarize everything else because it's missing a big patch right in the middle. So instead of being like a super highway going down the middle of these myocytes, it's like these little tiny one-way streets that are ticking me off every time I go somewhere up here. So they put a stoplight in the middle of it, and it has to work around it. That makes sense? Okay. I don't know if that's a new concept for anybody. I don't think we've ever done a really good job of explaining that in initial education of cardiology. Like the way it's described is it's a nerve cell that causes the heart to depolarize. That's the way I always kind of seen it described to us. So the filling of the chambers. So I'm not going to really necessarily beat this to death right this minute. We'll come back to that when we talk about the Wiggers diagram a little bit more. So the cardiac cycle. So one complete cycle is one complete heartbeat. So that is from initiation and contraction to relaxation and refilling. Cardiac output. This is another one of those things where you would need to remember a formula. It's not a complicated one, but I know I've said it multiple times. Cardiac output is heart rate times stroke volume. That will be something you'll have to know. As simple as it seems to figure out a cardiac output. It's heart rate times stroke volume. You need to, one, either know that it is heart rate times stroke volume, be able to pick out a question, or given a set of numbers, being able to calculate it. I know I've said it multiple times, but that's the give me question. You don't want to miss that question, miss a give me question. Stroke volume, so blood being pumped through the ventricle in one contraction. And speaking of gimme questions, and I'll squirrel on you for a moment real quick. Somebody said something about test anxiety yesterday. If you have test anxiety, I have test anxiety. I will say my way of dealing with that was outside of the test, like during the test. I keep a tally of questions that I'm like, I'm not, I had to guess at it. Okay, so I get to the end of the test and I have 10 questions, 10 tallies up there. I'm like, all right, that's 10, but the rest of these I know. I'm not worried. I'm not stressing myself out of it. Now they get up there and I have like 37 tallies. But just FYI. And on the, I don't think I can do it on the FPC test. I think you can do it in this CC. I think you can do it on the critical care ground test. You can make notes. Like I'll make notes to test writers just because I think some of their questions are crap, and I'll tell them about it. Like they get the note. Like if you make notes up there, you can come back to your question. You can see the note, but I make notes not just for my purpose, but for their purpose. Plus, you also get your scratch piece. So use it, make notes. If you have, if you can FPC test, you can come back to questions. Your CFRN test, you can't. But like when you're going through, okay, I'm not sure about this question. I got ABCD. I know it's not A. Move on. Or if I know that I'm going to go through and I'm going to answer every question that's short. I go through, boom, 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 boom. I answer the short question. If it's got a long paragraph, I'm not reading it. I'm going through and answering my questions. I'll come back to it. Just test taking strategy, and there's I got a whole thing on test taking strategies, but something that works for you to get through a test. The reason I say don't sit there and read a whole paragraph, because in the big mix of it, there might be only one portion of that question that's important. It might be the whole paragraph, but you don't want to get bogged down in your time focusing on one question when you can answer the other 90% of them that are short. So don't let it distract you. Sorry, squirrel for a moment. I apologize. That's why it's on the board. So I'll talk about how cardiac output's regulated. I'm gonna get through this and blood pressure, and then I'll promise I'll take a break and stop talking for a minute. Generally, we say the SA node is the pacemaker of the heart, right? What we say we've always said the SA node functions supposed to be between 60 and 100 beats a minute. What's actually it is the SA node wants to fire about 120 to 140 beats a minute, and parasympathetic innervation of the nervous system actually has the reins on that horse holding it back. So the parasympathetic innervation of the nervous system controls your heart rate and keeps that SA node in check to whatever your body may need. So it regulates your heart rate. You have different factors that affect the heart rate. You have hormones, epinephrine, thyroxine. So these increase the contractility of the heart. They increase the force of contraction, which increases the stroke volume, so which causes greater cardiac output, so which causes more blood to come back. The things that can cause the nervous system to react are crisis, stressors. Stressor could be I walk out here and that car almost hits me, or somebody jumps out at me in an alley in the middle of the night. That's a stressor or a crisis that causes your fight or flight response. The other thing is just exercise. As I'm exercising, I need more energy. My body's causing sympathetic nervous system activation because the skeletal muscles tell me I need more oxygen, so pumps more blood, try to oxygenate the tissues. Not really too terribly crazy of a concept. So stroke volume is usually remains relatively constant. So we talk about Starling's law. Starling's law is one of those important concepts that you need to know. Starling's law says the more cardiac muscle is stretched, the stronger a contraction is. So that means the more blood we put into it, the greater that muscle is stretched, the stronger the contraction. You can see this in if I blow up a balloon. I blow up a balloon to this balloon this big, it blows the air out at X, right? If I blow it up this big, it'll blow the air out bigger or faster. Yeah. If I'm stretching it, so when it contracts back, it contracts with more force. So that's all Starling's law is. It's just the more that the muscle stretched, the stronger the contraction is. The way we regulate the cardiac output on most instances is by increasing the heart rate. That's the easiest way to do that because we can only stretch the myocardium so much. So increase in heart rate because of the sympathetic nervous system, either a crisis or low blood pressure or low oxygen, epinephrine, thyroxine, exercise, decreased blood volume. I don't remember writing those up there, but okay, I probably did that yesterday. So, when you have the heart rate decreases. So we said the parasympathetic nervous system keeps everything in check, right? So that's what this is. This is a parasympathetic and your sympathetic nervous system keeping the heart rate in balance. And when the heart rate, when a stressful event happens, the sympathetic nervous system activates and becomes more apparent than the parasympathetic system with epinephrine, causing an increase in that heart rate. Needs to increase the blood volume, so it outperforms the parasympathetic nervous system. Once the crisis is passed, the parasympathetic nervous system or the sympathetic nervous system starts to decline. The parasympathetic system starts to take control again, and we see that start to take over. If someone has high blood pressure, or there's an increase in blood volume, or we have a decrease in venous return, you may see the parasympathetic nervous system activate more and start to try to control that heart rate and blood volume. I'm going to erase those. Nope, I guess not. I guess they're there permanently. So this is a microscopic picture of artery and veins, just to look at showing the difference in them. You can see the tunica media in this being the very thick muscular layer, the artery, and then obviously the larger, less muscular vein. The veins do have musculature for venal or for constriction, but it's not nearly as pronounced as that in the arteries. You see the tunica media in the venous system versus the tunica media in the arterial system. The other thing about lumens, the lumen in the venous system is a smooth lumen with endothelial cells in the middle. Same thing in the arterial system, but they have these valves to prevent that backflow. The venous system primarily prevents muscle contraction to move blood through. Endothelium, again, usually one cell thick. The tunica media is that smooth muscle controlled by the sympathetic nervous system, and the externa is the fibrous connective tissues. We talked about the thickness of the arteries versus the veins, and the skeletal muscles milking the blood through the venous system. That's what this diagram shows. The skeletal muscle contraction helping move blood back through the venous system. Capillary beds have what we call vascular shunts, if need be, by activation of the sympathetic nervous system. We look at the need to basically cut off a vascular supply to an area to try to, vascular constrict. True capillaries are where blood and oxygen are exchanged. Blood or oxygen and carbon dioxide are not just exchanged in the circulatory system, they're only exchanged in capillary beds. So there's no actual oxygenation going on in the arteries, so the actual lumens of the arteries themselves. All right. 5 minutes, and I'll stop this process. This is a busy slide, and I want to get the point of it. We all know that diffusion is how gas exchange and nutrient exchange takes place in the vascular bed. And diffusion is merely something moving from a higher concentration to a lower concentration. So if I have these two here, this is the semi-permeable membrane. This is my higher concentration. I have a higher concentration on this side. It's going to want to diffuse either the solute over here, or it's going to want to have or the solution over here, or it's going to want to have more solute over there. So basically, it's going to want to bring fluid from this side over here to make this even out. That's all I mean by diffusion. Erase all that because I didn't make that's ugly. The biggest point I wanted to talk about here is we have the largest molecule or the largest solute in the interstitial fluid in the blood is protein. Albumin is the biggest portion of that. So albumin is the largest protein in the body, or the most proliferative protein in the body. And if someone has low albumin in the vasculature, what do you think that does to the blood, the concentration? If they've lost albumin somewhere, do you think the concentration of materials in the blood is higher or lower? Lower. So if it's higher, if if the concentration of the solids in the blood, because we've lost albumin out of here, is lower than the interstitial space. So say it's 0.5 here and it's 1.0 here. What do you think's gonna want to happen? Yeah, it's going to want to take, it's going to want to even this out. So in order to even this out, I'm talking about this is the protein concentration here, 0.5, this protein concentration 1.0 here. Fluid's going to leave our vascular space to come to our interstitial space. We now have massive peripheral edema develop because the patient's got low albumin and they have basically your body is doing it. It's all it is trying to maintain homeostasis. It's trying to stay balanced. So the greatest propensity of the body itself to try to compensate, took all this fluid out and put it into the interstitial space, and now this person's got edema all over. Well, what happened to their vasculature? What happened to their circulating blood volume? Yeah, it decreased because they've lost, plasma. They've lost plasma to the interstitial space. So now we have a cardiac output problem because we're not circulating as much blood volume. They're not bleeding anywhere. They just lost the volume. All because of osmotic gradients and the body trying to compensate itself. Arteries, veins, I'm not going to insult your intelligence about what arteries and veins are, the arterial supply. Circulatory to the fetus, what we talked about. We talked about OB emergencies. Pulses, how to monitor, how to check pulses. Blood pressure. So we'll talk about blood pressure real quick, and then we'll stop after I get done with blood pressure, I promise. Health professionals, we obviously have to check blood pressures. You know how to check a manual blood pressure. We'll talk about invasive blood pressure monitoring today as well. So factors that affect the blood pressure. Neural hormonal factors, so generally on the sympathetic nervous system. Renal factors that regulate blood volume by altering the concentration, altering how much is circulating, and renin, aldosterone, angiotensin cycle in the kidneys affects blood volume as well. Heat has a vasodilatory effect. Cold has a vasoconstricting effect. And there are chemicals that increase, decrease blood pressure, diet, and exercise. This slide I put together last night because I didn't use it yesterday. I was like, don't think that all the factors of what affects cardiac output and blood volume did a real good job of it. So we say neural hormonal factors that affects blood pressure. You're talking about things that affect systemic vascular resistance, heart rate, inotropy, compliance in the venous system, and the handling of sodium and water in the kidneys. That directly comes back to blood volume, which affects preload, which affects feeding the system. And you have tissue factors, which affect systemic vascular resistance and other vascular factors, and the anatomy of the vasculature. All this comes together to affect blood pressure. That's how I probably do some more tweaking on this. But trying to put it all together, how everything is so interrelated, blood pressure is dynamically affected by neural hormonal levels. So everything from your sleep and wake cycles, circadian rhythms, your epinephrine being released to your circulating blood volume, your renal excretion, kidney function. You see patients that have a problem with their adrenal problems and their kidneys also have hormonal imbalances, which actually affects the blood pressure. really a perfect storm. The human body is amazing design. Just another factor showing the different things that affect, the factors of maintaining blood pressure. Nothing really different other than showing like intravascular volume is specifically affected by sodium and water retention, which is affected by sympathetic nervous system activation, aldosterone, antidiuretic hormone. We always talk about BNP and ANP in lab work. BNP is a marker of heart failure. We also, all it is just a peptide that gets released when the myocardium is stretched. Same thing with ANP. But that directly affects circulating blood volume. Come back to that. Let's take 10 minutes and I'll pick right back up on that. All right, reason I want to stop is because this is, I had the wrong guidelines in here because of the transfer of data over from the one computer to the other computer. So just a few months ago, guidelines for blood pressure categories have changed. And this is from the American Stroke and American Heart Association guidelines. We've always been okay, blood pressure, we want to keep it under 100. Under 130, 140. And now we're saying guidelines should be for folks to have their blood pressure under 120 systolic or 180 diastolic. That puts generally about, probably every one of us in the EMS in the category of having elevated blood pressure. And probably about 90% of humans. Or at least 90% of those of us in the United States. Elevated blood pressure categories being 120 to less than 130 systolic, or over 80 diastolic. So saying people with elevated blood pressure need to make lifestyle modifications, try to improve this. Everything from weight loss, stop smoking, to diet, to maybe the DASH diet, so something to improve it, not go eat 2 baskets of chips and guacamole and Chili's at night. That's probably not effective for blood pressure control. And then we're saying changes in stage 1 hypertension. Some blood pressure between 139 systolic and 80 to 90 diastolic. And we're treating people with blood pressures like this. If dietary or lifestyle modifications haven't fixed. I'm not saying we're treating, but just talking about what we're talking about hypertension in now. And grade 2 hypertension, I'm saying greater than 140 systolic or greater than 90 diastolic. That's pretty significant from a significant change from where we were. And then a hypertensive crisis, that hasn't changed. Greater than 180 systolic or 120 diastolic. We already talked about this, how capillary exchanges take place, diffusion across the membranes. We're going to cover developmental issues. Open this up. All right, hemodynamic monitoring. Well, This is my office every day. That's one of our five cath rooms and two EP rooms. So I always thought that was a really good picture when we first opened that newest room a few months ago. General considerations for hemodynamic monitoring. I'll talk about why we do it here a little bit, but I want to get into this diagram here. Did I show you all this diagram yesterday? Okay. Well, you're going to listen to me talk about it again to begin with. This, I'm going to go over it lightly to begin with, and then we'll come back around and revisit. So the Winger diagram has been in existence for over 100 years now. Like we say 1920, 20, okay, almost 100 years. Get where I'm at. All this diagram is illustrating the different cycles of what's going on. The EKG was not part of the diagram in 1920 because that wasn't in existence yet. But the pink line is the ventricular volume is moving along. The blue line is the ventricular pressure in the left ventricle. The red line is the aortic pressure. And the yellow line is the atrial pressure of the left atrium. And this at the bottom is your sounds. Heart sound 1, heart sound 2, and some people with your third heart sound, but that's rare, few and far between. You see the start up here, aortic valve opening, mitral valve closing, aortic valve closing, mitral valve opening. Dichrotic notch right here. All dichrotic notch means is you have two notches, right? Just two humps. And so if you're ever looking at your arterial waveform and you're looking for the notch, just think of it goes down and then has a dip, it goes back up. So that's your dichrotic notch. Your dichrotic notch is where the aortic valve closes. So we talk about blood pressure. We can monitor with a blood pressure cuff, or we can monitor invasive blood pressure, continuously with an arterial line. The blood pressure does not reflect cardiac output; it just reflects the pressure in the vasculature. So a blood pressure can be high, and the cardiac output can be low if there's vasoconstriction, and you can have a high cardiac output and a low blood pressure, with vasodilation. Central venous pressure is usually measured in the internal jugular vein, so it can be measured in the subclavian vein. You measure so it reflects the pressure in the right atria. We measure central venous pressures with usually a CVP line. Sometimes it'll be a Swan-Ganz catheter, which will show you all that here in a minute. And we generally use CVP to assess blood volume. This is what a CVP waveform looks like, and versus your arterial waveform. Pulmonary artery wedge pressure reflects the pressure of that in the left atrium. I'm going to show you the picture earlier for just exactly why it's measuring the pressure in the left atria. Normal wedge pressure is 6 to 12 millimeters of mercury. 6 to 12 millimeters of mercury. Cardiac output is usually, we usually measure that with a thermodilution. We can also do, in my thermodilution, this catheter is placed, however it goes, whether it's with moral or not, we place up through the vena cava, and it comes to lodge tip of this catheter in the pulmonary artery. Thermal dilution, we inject usually cold saline through this. It measures the temperature here, and it measures the temperature here. So that it's doing a mathematical calculation of the temperature variance to determine cardiac outputs. That's all, thermal dilution. We can also do a mathematical formula where we're checking the concentrate or the hemoglobin concentration of oxygen in the superior vena cava and in the pulmonary artery, and figure out mathematically what the output is by how much hemoglobin is consumed in that short period of time. But that's not really, that's beyond anything we need to cover. We know what an EKG does. ABG is probably, and I have a whole day on ABGs later this class, is one of the most important lab tools that we can have for a number of different reasons. By assessing our pH within the body, PaO2, PaCO2. So if a patient's on a ventilator, your ABG is profoundly important, right? Like basically, it tells us what we need to do with our vent settings. Oxygen saturation, you know what SpO2 is via a finger probe. Mixed venous saturation is where we're actually taking a mixed venous gas from a pulmonary artery catheter. Usual mixed venous concentration is 65 to 75%. A low mixed venous concentration may actually indicate inadequate tissue delivery because we're having impaired oxygen offloading with the tissues, so it's taking longer. So we're having more oxygen consumed out of the blood before it gets back to the venous system. Lung function is a mathematical formula between the gradients of the gas exchange and internal CO2 gradients. We can use to assess the adequacy of ventilation. We'll talk about those. We'll get to vents. Respiratory compliance. We'll talk about with vent settings later in this, so I don't want to get into that at this point. Capnography, I'm not going to beat that one to death today. Organ and tissue oxygenation. Ultimately, everything we do, regardless of what type of patient, whether it be a trauma patient, whether it be a medical patient, whether it be a patient having a stroke or having an MI, what we do falls back on this, right? It's the goal is to oxygenate the tissues regardless of what's going on. So, we're looking at things that will increase the, oxygenation of tissues. We're doing interventions to try to increase our oxygenation of tissues. Increase in lactates concentrations will indicate that we're having metabolic acidosis, which suggests anaerobic metabolism. We talk about that real briefly in the initial education. We talk about the aerobic metabolism is with oxygen. Yeah. Anaerobic metabolism is the Krebs cycle without oxygen, and it produces much less ATP, but also has a byproduct of lactate and pyruvic acid. So we see that basically concentration of byproducts build up. Okay. No problems. So lactate can also increase with sepsis, but when we're looking at, we talked about it briefly, and you weren't here when we talked about the oxygen hemoglobin dissociation. A little bit. Okay. So we're talking about this. Something that would cause the oxygen, sepsis is an increase in our sepsis. Acidosis is causing an increase in our hydrogen ion concentration, causing a shift to the right, impairing our oxygen and organ and tissue oxygenation. So a mixed venous sat of less than 55% which is a saturation from the pulmonary artery or the superior vena cava, is an indication of global hypoxia. It should not be that low. Organ-specific measures, urine flow, and this is, we'll say a poor man's CVP, is a Foley catheter. You don't have to have a central venous catheter to assess fluid resuscitation. You don't have to have it to assess, assess volume. We can look at it as what our output is in our Foley catheter and our patient's transport. So that's why I say when you're getting your patient, one of the first things I do is I empty the Foley catheter, because if I have that patient for 2 hours, I want to know how much urine output is going to actually happen. Practice doing something, actually.
So if the 1 million like gold kind of thing,
Yeah, that is
30 hours.
now that is normal tissue or normal output is 1 ml per kg per hour. So if you're 100 kgs, you should be producing 100 mLs of urine an hour. Normal.
So if you're over 30 hours, that's good, because I remember hearing about like 30 hours.
So yeah, that is the minimal we want to talk about. People are different. So if someone has renal failure or they have reduced renal perfusion, their urine production is going to be less for obvious reasons. If they have an elevated creatinine, they already have a urine problem. So you have to take that into consideration. Just because I have a patient, I want to know when I go and assess my patient at bedside before I even get them, I empty the Foley catheter. Okay, I'm emptying 120 mLs. When was the last time this was empty? If that's what they've been having consistently, 100, 120 mLs an hour, okay, good. I got a good ballpark. That's probably normal. If they're already behind the 8 ball, if that's been 6 hours, we're way behind the 8 ball. So everyone's a little bit different, but 1 ml per kg per hour is a normal, healthy individual, not accounting for disease process. So that everyone varies just a little bit. We won't talk about that. All right. Arterial waveforms, and I'll talk about this is arterial. Pulmonary artery waveforms. And this is probably the easiest illustration of what these look like. Because you place the waveform down here in the right atrial, and you're not going to necessarily see this as much a right atrial waveform, because we're not going to have a catheter floating into the right atrium, be a transport. So, but to illustrate right atria, you have this very low amplitude waveform, normal pressure between 0 and 8. Right ventricle is this deep systolic and diastolic waveform. Generally, normal should be 20 to 30 systolic, and 0 to 8 diastolic. A right ventricular waveform, you need to know if a pulmonary catheter slips into the right ventricle, it will irritate this, and eventually could cause VTAC, it can cause VFib. And basically, if it gets there, you need to remove it. You see that waveform develop on your pulmonary artery catheter, pull it back. We can always pull the catheter back, and we can pull it back into the vena cava, and it'll be A-okay.
So do you pull back just enough to where you stop seeing that, or is there a marker on there where you pull back to?
So you would pull it back till you stop seeing this. You can pull it back till you see a right atrial waveform. That would be acceptable. I'll usually pull it back till I see a right atrial waveform, and then just remove it further. Because it can hang out in the vena cava. There's no valves there. It's not going to cause any problems.
But if I see that on the test question, did it say pull back until I see change the waveform, or did it say pull back?
It will say it would say something like pull back into the superior vena cava. I don't think it'll actually have a question like that, but it very well may have a waveform like this as to what's going on. Why is this a concern? If you have a concern about pulling it back, call medical control, but the patient's not going to tolerate that very well. Their heart's still usually going to be a normal rhythm, but they're going to start throwing PDCs. They're going to go to VTAC. It's not going to be fun. Usually, even if the patient does go in, especially if they're in VTAC, if they still have a sinus rhythm, okay, you got to get it. Maybe call them, see what the hell they want you to do. And maybe you're like, oh, well, he's been tolerating it, but it's not going to be very long. Usually, if they're in VTAC and you pull that back, that'll immediately go back to normal. If they don't, we can fix that. But if they're in VTAC and you have that waveform, pull it back until you see that resolve and hopefully the ventricular rhythm will resolve. This is a pulmonary artery waveform. You see it's not as deep, and it's not nearly as, we call this ventricularized, the way this waveform looks. It's much wider, so its systolic pressure for a pulmonary artery is generally about the same as the right ventricle, but the diastolic pressure is higher. And you'll see some patients have extremely high pressures. Like someone has elevated, like if they have a pulmonary hypertension, their pulmonary artery pressure might be 45 systolic. I mean, that's high. So just knowing what it is before you ever leave is always good. We will transport patients with a pulmonary artery catheter in place. It stays in place in the pulmonary artery, and this is where if it dislodged, usually it will come back into the right ventricle. That's where you'll see the changes from this waveform to this waveform. That's where we have to do something. I don't encourage, like my practice will re-advance it, but we don't, so we don't do that in the back of the truck. So because if we advance it, we have to actually advance it across the pulmonic valve. So, and the reason we do this, we're assessing, so it'll stay there and talk about assessment of values here in a little bit. The other thing that could happen is wedge, a pulmonary artery wedge pressure. And this is, I got a better view of pulmonary artery wedge pressure a little bit later. There's no defined wedge pressure like that I can say, yes, this is a pulmonary artery wedge pressure. You're not going to see one on a test because they vary so much. So this, this one here is their illustration, but you may see pulmonary artery wedge pressures. I say that my drawing is not great. I apologize. It's all over the place, but usually this is a respiratory variation. So you see it, we call it like it's a rolling pressure. Generally, you have the atrial, ventricular contractions, and then it'll drop, and then you have an atrial ventricular contractions. They're not nearly as pronounced. They're not nearly as high because, again, they're beyond the actual pressure. They're actually reading the pressure back. The problem with, and you should never have a wedge pressure en route. We don't check a wedge pressure while it's going down the road for a number of different reasons, because if the catheter got permanently wedged, we can have tissue necrosis happen in minutes. So wedge pressure en route is very, very dangerous. So if you were to see that, we need to make sure the balloon is deflated. And if we can't, if it stays wedged, contact medical control, find out what they want you to do. Usually it'll be pull back. If you happen to find resistance, you don't want to pull back because it can migrate forward and wedge with the catheter tip, pulmonary vasculature. So the Swan gains catheter. This is a design. It's not a brand. It's a general design. It was initially developed. We used it really consistently for MIs, but now we use it for sepsis. We use it for patients in surgery. We use it for monitoring and medication therapy. So we use it for a lot of different things. We'll use it for diagnosing of heart failure, cardiomyopathy, pulmonary hypertension. We can use it to evaluate immediate changes for medication therapies, because while a blood pressure might be one thing, I can use it immediately to evaluate cardiac outputs. We can use it immediately to evaluate invasive pressures, how well the circulatory volume is functioning in the patient. I use it for CHF, so all types of shock, neurogenic, cardiogenic, septic, anaphylactic. And if a patient has decreased urine output for whatever reason, that's a poor man's CDP. If they're not producing urine, I have trouble assessing their actual cardiac output. This will help me overcome that. And so we see these placed subclavian, or see them placed through the neck, through the subclavian, then through the arm, through the leg. So that's a number of different placement options. This is a 3-port catheter here. This has this is actually just a 2-port catheter. One has to measure pressures, and the other one is to shoot outputs. So can't exactly administer medications through this one, but they do have them where there's 4 outputs where we can actually administer medication. When I say the balloon is, when we wedge it, we actually inflate a balloon on this. And just like anything else, if this were any other vessel, that balloon's in the pulmonary artery, and it is now, say it's over here in the right pulmonary artery. What's going on beyond that pulmonary artery? That balloon's blown up. Yeah, it's occluding the blood flow. So we're using that to measure the pressure in the left atrium. But if this is in that wedged position, we're occluding it. So that's why I say you can cause necrosis of the tissues very quickly. So a couple of important points about these things. If you're going to transport one for a patient, know where it is at the skin, where the marker is. Each one of these is 10 centimeters. You have 1, 2, 3, 4. The big one's 50. You go 1, 2, 3, 4. The next 2 are 100. So if it's at 62, or 62, I know that it's at 62 when I start, and I know it's at 62 whenever I get to where I'm going. That's one of those questions that they will want to know. What's the marker at? Is it 62? Well, it's still where it was. Always have this syringe with it. You can attach to it, and then I always go through and pull back on it and then lock this in place to make sure that balloon is deflated. If you were to leave that open, it could accidentally get inflated even a little bit. Wedge back. So I say always pull back on it, hold it back. These syringes, there's nothing really unique about them, other than they have a little the little notch. It's to keep the plunger from coming out, because technically it only needs 1.5 mLs of air to weight that pulling. I will pass this around and play with it. You see fit. There's nothing really complicated about it. It's a hollow tube that measures pressure. It measures pressure on the inside of wherever it is in comparison to the atmospheric pressure. Normally, there's 4 ports. That's the only one I had for training. It only has 3 ports. So, just FYI. Proximal port is used to measure the right atrial pressure, and it's also used to inject for cardiac outputs. The distal port we use to measure the pulmonary artery pressure, and the balloon port is used to determine the wedge pressure. That's where what that syringe is hooked up to. And then what that one's lacking is an infusion port, where we can infuse fluids or administer medications if we need. We generally try not to administer intracardiac medications, but sometimes we have to. But we can perform a large amount of fluid resuscitation through these things. That one right there is 5 French. No, it's 4 French. No, I'm sorry. That is not the same catheter that I have here, because it says it's a 4-lumen catheter. That's a 4 French. Output catheter. Sorry. So that's a 7 French catheter. 7 French is rather large. It takes usually that will be in the leg, but we do place some subclavian. We do place that size catheter in the arm. Just depending on what patient condition is what size we need to. We can infuse a large amount of fluids through 7 French catheter. We already talked about that. Phlebostatic access. And this is one of those things you will see again. Phlebostatic access is the 4th intercostal space mid-axillary line. This is the approximate level of the right atrium in a patient. So if you encounter a situation as to where the transducer must be for a patient, it wants to be the phlebostatic access. Critical thinking, why the phlebostatic access or why we put it there is important is because it's at the level of the right atrium. I'm not going to insult your intelligence about what these are. We're going to talk about them a little bit, but preload is the degree of muscle stretch present in each ventricle before systole, or the amount of blood in the ventricle before it contracts, also known as a filling pressure. Left ventricular preload we measure with pulmonary capillary wedge pressure. Right ventricular preload is what we call the central venous pressure, or the RA pressure, right atrial pressure. Afterload is any resistance which the ventricles must pump against. It can be the peripheral afterload, so it'd be the left ventricular afterload, or the right ventricular afterload, which is the pulmonary vascular resistance that it has to pump against. Cardiac output, we talked about that, what makes up cardiac output, and cardiac index. Index, I'm not going to get the calculation of the cardiac index, but just know that cardiac output is your heart rate times your stroke volume, and cardiac index is the cardiac output adjusted for a body surface area, because somebody that's 5'2" and 450 pounds has a different body surface area than me, who's 6 foot and 190 pounds. So we might have the same cardiac output, but our index is dramatically different because of our size. I'm not going to adjust that. Systemic vascular resistance from an afterload, that's the right ventricular afterload. So this is, I threw this in here this morning as far as shock and systemic vascular resistance. So normal systemic vascular resistance is measured in what called dynes. And the only way I know to compute dynes is, I mean, there is a mathematical formula, and I don't expect anybody to know what the mathematical formula is. But is 700 to 1600 dynes, which equates about to 9 to 20 millimeters of mercury. So if a patient has a low systemic vascular resistance, we generally say is distributive shock. So if or a patient in distributive shock will have a low systemic vascular resistance because they're doing what with distributive shock? Yeah, they're dilated, so they're vasodilated. So they opened up the systemic vasculature. In a patient with septic shock, we'll see they'll have a high cardiac index. They'll have a neurogenic shock. So I don't like now that I look at this slide, I don't really like the top part. So I'm going to come back to that part. But let me come back to this whole concept in just a little bit, and we'll skip where I was going with that. But oh, the next part wasn't even there. Transporting patients, because this is in kind of an awkward spot to bring this up. Transporting patients with a central venous catheter in place, you have a increased risk for infection, right? We have a foreign item in the body. Just like an IV is an increased risk for infection. Right? So what do we do to our IVs? Obviously, we insert them aseptically, and then we do what to them? We put a Tegaderm on. Yeah. We put a Tegaderm over them to try to protect the site. Same concept for this. If you're going to transport a patient with a central venous catheter or pulmonary artery catheter, make sure it's dressed. Make sure it's covered. If the dressing is saturated or it needs to be changed, let's do that before we leave. We don't work in the cleanest environments. Our trucks, we're terrible for our sterile technique. So say use use an occlusive dressing to cover this. Make sure we can try to prevent any introduction of infection. Other things, air embolism may occur when a balloon ruptures. If a clot comes at the end of the catheter, it can result in a pulmonary embolism. Usually these things are primed with heparinized saline in order to prevent any blood clotting, but it could happen. Life-threatening emergency, catheter wedges permanently. If you see a wedge pressure, or if you see the catheter is wedged while we're en route, that is an absolute emergency because it will cause that necrosis. If the waveform looks like a PA waveform, but it's generally flatter, this could be because it's inflated or it's just migrated further into the pulmonary artery. We talk about ventricular irritation. When it migrates it back, or it can loop, it can cause VTAC. They're in VTAC, pull it back. If it's just a ventricular waveform, contact the MD, but you're en route, you're going to have to do something. They're not going to do much on the phone, right? They're going to tell you, pull it back. Dampened waveform. This generally occurs when there's a defect in the heart or the catheter itself. This can be because there's air bubble in the system. It could be there's a kink in the line. So before, if we have this waveform right here, and this is a normal waveform, or I take it back. If you have this PA waveform, and this is what you've been seeing the whole time, and then all of a sudden we have the same waveform. It's the same PA waveform, it's just dampened, right? It's just low. It's because something has most likely because something is occluding the system. It's there's air in the line. There's something that's kinked in the line and it's not able to read correctly. So always try to follow your line to make sure there's no air in it, make sure there's no kinks in it. No waveform. If everything's working correctly and there's no waveform, check the patient, make sure the patient's alive. If the patient's alive, then we can go look for problems with the equipment, because two issues with no waveform: patient's dead, or we're having an equipment problem. So non-perfusion arrhythmias will actually cause the waveform to go flat because the heart's not doing anything, right? Or the lines become disconnected, or the machine has had an error. You got water into the terminals, the transducer could be wet, something's broken. That would also cause no waveform. So first step, no waveform, check the patient. I'm not going to go into inserting. So
yeah, if we transport these patients, the transducer, do we need to reset the transducer once we get to, like, if we're flying and we get to a certain height?
Yes.
Do I need to?
Absolutely, yes. Generally, because so we're not going to have, and we'll talk about balloon pumps this afternoon again, but yeah, the atmospheric pressure changes. So we'll open the transducer to air, zero it, and then close it back off. So that's the biggest thing we can do. Always making sure that the transducer is at the level of fluid static access. And I didn't really beat that one in. When you're transporting them, take the transducer to the fluid static access. Some of these patients, they may have that central venous line that is in their neck or their arm or through their subclavian. Those patients can sit up. If it's in their leg, they're not going to be sitting up. So, but if the patient can sit up, they're probably not going to want to lay supine the whole flight. Now, if we're in a helicopter, they don't have too much of an option there. But if we're in a fixed wing aircraft, absolutely, they need to do that. As far as in a helicopter, it's not going to be that big a deal. But for pressurized aircraft at 10,000 feet, yes, it's a big deal. To re-zero that, to make sure we're on the same page. And on that note, if there's air in the line anywhere in the transducer at that point, that could be an absolute problem, because that air bubble is going to expand and it's going to change all of our waveforms at that point. If you suspect there's air in there, if you have a problem, you say trouble, the waveform, the dampened waveform, don't just flush it to the patient, because if there's air in there, we don't want to do that. Whichever line your transducer is hooked to, so we'll usually we usually do this with heparinized saline. You'll have a pressure bag that usually have heparinized saline. We'll draw back on that to get blood return, make sure there's no clots. Once we have blood back, we'll inject back with heparinized saline and then reconnect our line that is not that's been flushed to make sure there's no air in it. Then you can flush the line just to make sure there's no air. But we absolutely do not want to flush any air bubbles in the system. Just like any other, that's a concept that's not really that foreign, but just amazed how often that actually happens. There's something else I want to mention about that. I don't remember what it was. So I kind of just put this in here for illustrative purposes. When you put them all together, this is what the progression, when we're actually advancing these catheters, this is what you see. This is a right atrial waveform. This is a right ventricular waveform. This is a PA waveform. And this is the wedge waveform. The wedge waveform you just see is really just the dampened waveform of the PA, because the catheter is not moving anywhere. We're just inflating that balloon and wedging it in the artery, unless the catheter migrates itself. So if it migrates to here, I would pull it back until we see this. If we get it too far back and we see an RV waveform, then you're going to just have to keep pulling it back. If you encounter resistance, pick up the phone. If you pull and that is actually like, I'm pulling, there's actually a resistance, we need to be careful because it could very well be wedged in here. Comparison of the waveforms to an EKG. So this is just putting them all together. Atrial, ventricular. Remember, electrical occurs before mechanical. So your electrical, atrial depolarization, and then a fraction of a second later, atrial contraction. Ventricular depolarization, ventricular contraction. I should not be using this pointer. I'm sorry, folks. So I was just pointing electrical, mechanical, electrical, mechanical. And then where we're going to transport these most of the time in the pulmonary artery. This is a pulmonary artery waveform. And then this is the pulmonary artery wedge waveform. This is if the catheter has wedged itself all the way into the pulmonary vasculature, so just be cautious of that. You asked about zeroing it to phlebostatic access. We try to always read the central venous pressure at the end of expiration. And why do we want to measure it at the end of expiration? What's going on in the thorax when we exhale? Okay, so we're having that, we're changing that intrathoracic pressure. So if we always read it at the end of expiration, then we're looking at the unassisted central venous pressure. If we were to read, the patient was to breathe in, we're increasing the pressure on that vasculature. So yeah, you're right on point there. The other thing is making sure you always read it in the same place in the respiratory cycle every single time, because it changes dramatically. Just like this right here, this is what I'm talking about, respiratory variation. This is just as the patient's respiratory cycle. I think I have a better view of that. This is pulmonary artery waves compared to an EKG. We talked about that a minute ago. Comparing wedge pressures to pulmonary artery pressures. Generally, the wedge pressure should always be lower than the pulmonary artery diastolic pressure. So always know where your pressures are. The mean pulmonary artery pressure should be lower than the mean, or the mean pulmonary wedge pressure should be lower than the mean pulmonary artery pressure. If I can articulate what I want us to say here. I have a set of like self-learning packets too for pulmonary artery and arterial lines. So I'll make sure I get those to you guys. I'll get Glenn or myself to email them out to everyone, or I'll put them on my Dropbox and share them. I will say, if I share something with you on Dropbox, there will be a time limit on it. So it'll probably be like 3 months, but or the end of this class. But last time, it's only like 6 months later, so hey, I wasn't able to get those files. There's a time limit on getting that stuff. So if I share a Dropbox link to you, it does expire, just FYI. I probably won't be the PowerPoints themselves, but it'll be, I do have, I told these guys last night, every time I go somewhere and if I'm able to get learning packets from people. Like I've got Orlando Hospital's learning packets. I share those with anybody I can, but it's not that the time limit is because I don't want y'all to have it. It's just because I have to maintain the sharing property on the Dropbox. So take it while you can get it. If you don't get it, I might not be able to remember to do it later. So respiratory influence on your waveforms. This is a wedge pressure waveform, and this is much better of a rolling waveform illustrating here. So you have the end of expiration here, the increase in our intrathoracic pressure. And then we have our inspiratory artifact. This is not an accurate reading for us because the intrathoracic pressure change. So expiration is we see a rise in that pressure. And just prior to that drop for the inspiratory change is where we're looking at what the actual wedge pressure is. I'm not going to go into reading and output because we're not going to shoot outputs while we're transporting patients. I will say though, the learning packets I have do have information about outputs if you want to know. It absolutely covers that stuff. Reading a PA waveform, or said we read it at the end of expiration as well. The dichrotic notch on a PA waveform is the closure of the pulmonic valve. It should always be on the right side of the wave. If the notch is on the left side of the wave, you may see that the tip of the catheter is actually migrated into the right ventricle. So that would be where you want to look at what our waveform is. All right. Why all this is important? Waveform and all. And the top part of this is really what I want to talk about. So for a patient with, we'll talk about the right atrial pressures first. Normal right atrial pressure is measuring preload. Normal is an average of 4 millimeters of mercury. If we see a patient who's in hypovolemic shock, we'll see a low right atrial pressure because they have a low circulating volume where we've lost volume in the vasculature, so we don't have it there. If a patient's in cardiogenic shock, what's going on with them? They have what kind of problem? Cardiogenic shock, the pump. We have a problem with the heart. It is not working the way it's supposed. We don't have a problem with volume as much. We could, but so because of that purpose, or because of that issue, we're going to see an elevated right atrial pressure because we have all this volume coming back into the heart. The heart's so weak, it can't work. For a patient with septic shock, it may be normal or it might be slightly decreased. It just depends. For a wedge pressure, and again, this is not one of those things you need to know, but you're not going to necessarily be doing wedge pressures. Normal wedge pressure is about a mean of 9. Hypovolemic shock, patient's wedge pressure is going to be low because they got a slow circulating volume. Cardiogenic shock, same thing, wedge pressure is going to be high. And they may, for sepsis, they may be normal to slightly low. Cardiac index, I mentioned it briefly, and like I said, I don't necessarily need you to know the function of the calculation of cardiac index. Just know that normal cardiac index is 2.8 to 4.2 liters per minute per meter squared. Normal. That changes based on it is the output accounting for the patient's body surface area. So a patient with hypovolemic shock is going to have a low cardiac index because, again, low circulating volume, right? Cardiogenic shocks, they're going to have a very low cardiac index because This is measuring the output, cardiac output, and function of the heart itself. Septic shock, they're going to have usually a high cardiac index because the body is trying to compensate, it just can't keep up. So it actually doesn't have as much of a volume problem as much as it does in open vasculature. So it's pumping to try to circulate a volume, and it's got this tank that's just way too big. Afterload, we talked about the measurement of afterload in dynes. I'm not going to, kind of cover how to calculate a dyne because it's an algorithmic formula. So if you were seeing that on a question, it would say increased systemic vascular resistance or a low systemic vascular resistance. It's not going to give you a measurement of dynes. But patient with hypovolemic shock is going to have an increased SVR. Cardiogenic shock, they're going to have an increased SVR. And systemic shock or septic shock, they're going to have a low. Fire, they're going to have increased peripheral vascular resistance or cardiogenic or hypovolemic shock. What's going on in the body? They've lost blood. So the body is activated sympathetic nervous system. So what's happening? You're going to increase heart rate, right? But peripherally, what's happening? Vasoconstriction. So that vasoconstriction, we see an increase in afterload, which was increasing that peripheral vascular resistance. So that's what we say that's why we'll have an increase in SVR. This right here, this concept of systemic vascular resistance and preload is always good for about 2 questions to understand what's going on in the body with a patient in hypovolemic shock or cardiogenic shock. Understanding why they have a low preload or a high preload or a high afterload. There are, like I said, it's always good for a question. I think I actually have one here. Let's see what I got. Let's see. I know I have some questions on here. So here's a example. You have a 16-year-old male who's involved in an auto pedestrian accident. His blood pressure is 78 over palp. His heart rate is 124. His respiratory rate is 30. The patient's disoriented. Your best intervention for increasing preload in this patient would be, and then it gives you some options. So the first option is administer epinephrine IV. Option B, administer dopamine IV it doesn't give you a rate, but we'll say 10 mics per kg per minute. Administer or infuse a crystalloid solution of 20 mLs per kg, or place the patient in the Trendelenburg position. Yeah, I think infuse fluids would be the best thing. So that's kind of the description of the way we can describe those instances, a question like that. Another one, and this is one to, I'm not going to tell you how the question is designed, but I'll read it to you first. You're dispatched to transport a 22-year-old male whose house caught fire after he fell asleep while smoking. See, another reason you shouldn't smoke.
That's why I vape.
That's why you vape. Okay. Yesterday, he sustained 30, so this was yesterday, he sustained 35% deep thermal partial thickness burns. I know we hadn't talked about trauma or burns, but to his arms, neck, and torso. Which lab value below would be the best indication that the patient has received adequate fluid resuscitation? So sodium is 139. We have not talked about lab values all that much. His cardiac index is 2.2 liters per minute per kg or centimeter or meter squared. Sorry. His hematocrit is 63%, or his urine output is 42 milliliters per hour.
Does it give us a weight?
Does not give you a weight. So
it's asking you what would tell you that his.
Which lab value would give you the best indication that there's been adequate fluid resuscitation?
I would say your sodium, because that's normal.
Okay. So this is a question to throw you off, is what it's designed to do. It's actually going to be your urine output, but you have to consider he's got 35% deep thermal burns, so his urine output's going to be altered. So his urine output's not going to be 1 ml per kg because of the burns. So the 42 mLs per hour is going to be actually accurate for him. So
all right. So I guess that's where I'm having trouble drawing that one. We don't have a weight. It didn't give us a weight to go by. So. Right.
It did not give you a weight to go by, and that's that may be the question that that this is not their question. This is a group of questions that a group of instructors has written. So we may have neglected to put that in there. So I
will tell you from nursing school, they always, like you said, the gold thing is to figure it out 1 ml per kilogram. But like I said, what we were talking earlier, I've always been told as long as it's above 30.
Yeah, as long as it's above 30, especially in that burn patient.
Right.
Yeah, normal is 1 ml per kg per hour. But that's a normal patient. How many times do we have a normal patient? So you are right on that point. So let's see what I got here. Try to come up with another one. That's not a good one. All right, so which of the following hemodynamic parameters is most indicative of cardiogenic shock? And it's going to give you some parameters. I'll write them down since I can't transfer from one to the other. So number one, we'll write down. Let's do, then there's that. So number one is, so we're going to go systolic blood pressure, we're going to go with cardiac index, and then wedge pressures, right? So systolic blood pressures, first one's 80 and 30. And that's what, hopefully y'all can read through my my mess here. 92.25. You just might not be able to read my handwriting. And then we have 124.12. And then 143 and 8. All right, so looking at these numbers, I know my handwriting sucks. I'm sorry. So this would be an example of which one of these would indicate that the patient's in cardiogenic shock. Or one. You call it one. Yeah. So why?
Capillary wedge pressure is elevated.
Capillary wedge pressure through the roof. You're hypotensive. So your index is going to be low. So your index is really low. Your wedge pressure is really high, and your index or your blood pressure is low. So this one would be one of those. They're in cardiogenic shock, right? First thing that tells me is shock is scratch these out because this is not shock. They're not always going to be that easy to throw out, but I know it takes a lot to walk through me writing that down, but I'm trying to give you some examples of what kind of questions we would see arise out of this. So let's see. A patient with an extensive anterior MI has a blood pressure of 88/60. Are they hypotensive? Okay. So they have a pulmonary artery wedge pressure of 8. Is that normal? I need to.
It's 4 to 12, right?
Yeah. So we'll say it's 8. So 8's pretty close to being normal there on a mean. For the mean pressure, it's right on target. They have an index of 2.0. So that's low, right? Which of the following would be the best description of this patient's condition? They have a decreased cardiac output secondary to reduced myocardial contractility. They have fluid volume overload secondary to decreased cardiac output. They have a pulmonary hypertension, or they're in cardiogenic shock.
You repeat it one more time, I'm sorry.
So which part? The options? The questions. So you have 88/60, wedge pressure of 8, index of 2. He's has an extensive anterior wall MI. They want to know what the problem is, essentially. Decreased cardiac output secondary to decreased myocardial contractility. Said cardiogenic shock. Fluid volume excess secondary to decreased cardiac output, and pulmonary hypertension. Yeah, so it has decreased. Said it could be 2, right? Because they have decreased cardiac output secondary to myocardial contractility, or that's the definition of cardiogenic shock. So I said these aren't the actual questions. These are questions we wrote for discussion because those say the same thing: cardiogenic shock or decreased cardiac output related to myocardial contractility. That's the same thing. But I just wanted to illustrate how the questions will use this information. Because, and I'll give you, there's a better way of putting a prettier way of putting all this together. I like the fact that this shows the arrows to kind of throw a graphic representation. But if you can memorize the values, and then understand, put the arrows in your head. I don't need you to memorize that. You know, some people, if they just dump and unload their brain, that's that's what works for them. That's what works. But if you just memorize the values and remember that in a patient with hypovolemic shock, they're going to have a low wedge pressure, or if they're cardiogenic shock, they're going to have a high wedge pressure. If you can just know the value and know which one's which, then remember that, then you can apply it in the question. There's no sense in missing questions based off of numbers. It's not asking you to calculate it. It's not asking you to, or they're not going to give you a waveform and say, what's the pulmonary artery wedge pressure? It's not the way it's going to do it. If they give you a waveform, it's going to ask you what the waveform is. All right. Arterial waveform versus, I think this is right where y'all came in yesterday. So we're wrapping up before lunch, or wrapping up everything to get where y'all were when we started yesterday. Can we take? Yeah, let's take a break. We'll take a break, and then actually, if you want to take 15 minutes, I'll be done, and we'll take lunch. Yeah, let's do that. Let's just go 15 minutes, and we'll be done for lunch. Oh, by the way, my goal is I need to be out of the parking lot here, on the road at 4:30 today, just so you know. If we get through what I need to get through, we'll make it happen. These guys are going to head back to Spartanburg right after we get done with this, so it'll just be you and me, Glenn and I hanging out. So the importance of this right here is being able to look at an arterial waveform and say, I know what the blood pressure is. Your computer is going to interpret MAC. It's going to, where did I put my little marker? So in this waveform, I'm going to put, this is 120. So this diastolic, so down here is 80. So your MAC is going to be automatically configured. Your 120. It's terrible, sorry. So it's going to have a systolic, diastolic, MAP, just like your non-invasive pressure is on your arterial monitoring system, regardless of what the numbers are that I'm going to create. Just know the systolic, diastolic, MAP. Your systolic pressure is the top of the waveform. That's your peak pressure. Your diastolic pressure is the bottom of the waveform. This is what an arterial waveform looks like. This is the dicrotic notch. The dicrotic notch is the what? It's the closing of the aortic valve. I thought that's what you said. No, okay. That's,
hey, good to go, sir.
Yeah, sorry. My hearing sucks anyways. So, but yeah, so the dicrotic notch is the closure of the aortic valve. There's nothing really you have to do to look at an arterial waveform. That's super complicated for our purpose, transporting. The biggest thing is it gives you a dynamic monitoring of patient's blood pressure, but that's really all it tells you. If you only have one hemodynamic monitor and you're going to transport a patient with a CDP and an arterial waveform, monitor the CDP. Because the art line, it's just a catheter in the artery. Might be a radial art line, might be a femoral art line. It's just a catheter in the artery. The CDP is a catheter in the heart, usually. Won't really monitor that. Plus the CDP actually gives us a volume status, and we can interpret everything else from that. So if I have my choice, I only have one line I can monitor. I'm going to monitor the pulmonary artery line because I need to know if it wedges. If it wedges and I'm not monitoring it and I can't, that causes a huge problem. So you can always just monitor this and flush it as you go, even without monitoring it, or even without it being transduced. All right, we're back to this diagram. And the reason this diagram is important,
We have snacks.
well, we're about to have lunch, so
Well, I was gonna say, do you wanna have snacks and skip lunch?
I don't care.
And get out an hour early.
We're going to finish this lecture right now. We'll cross that bridge.
Okay.
So, what's going on in the body with each one of these waveforms? So, we're looking at the ventricle here, and the ventricle and the aorta. The blue is the ventricular pressure. So, the yellow being the atrial pressure. The SA node fires down here. The atria starts to contract. It increases the ventricular blood volume because it's providing that atrial kick. At that point, the mitral valve closes. The aortic valve's not open yet. The aortic valve and the mitral valve are both closed at the same time. The aorta or the ventricle is now a closed container, and it starts to contract. And it starts to contract, and this is what we call isovoluminar contraction. Isovoluminar means basically it's contracting by itself. It's just contracting on itself closed. And it starts to launch that pressure upward until it gets to here. The aortic valve opens, and then it expresses that blood into the aorta, and it's perfusing the body. Once it gets to here, this is where the valve opens, the blood starts to go out, so the volume starts to drop in the aorta, and we're expressing that blood. When the pressure equalizes between the ventricle and the aorta, and pressure in the ventricle drops below what pressure in the aorta is, aortic valve slaps shut. We hear S2 down here because the blood is splashing against the valve. So that's what we're hearing. And the vessel starts to relax. We see at the dichrotic notch is the aortic valve closure. And then the pressure gradually declines in the aorta until we start the process again. The pressure rapidly dropped in the ventricle, and we're in diastole until atrial contraction and atrial kick, and then we start the process all over again. So I always just like to start it with a Wigger diagram and end it with the Wigger diagram to kind of bring it all together. Erase all that. Same diagram, but I add in this the central venous pressures. And then the pressure in the left, in the flow in the aorta. This is just it's not the aortic pressure, this is the actual flow in milliliters. But your central venous pressure when this is going on, so your central venous pressure is high. We have that kick in here. And then the central venous pressure drops as the ventricle during systole, and then gradually goes back up. So that's all, just trying to bring it all together. And then you look at the time frame. This is systole, 1, right? So I have systole, and then 2, the diastole. So your systolic, and this is 2, your diastolic. And then dividing it all by 3, that gives us our map. So that's where we're coming up graphically. And I know I beat that one in your head. It's been beat into our heads over the years, but I like to have it graphically because I'm a visual person and that's the way it works for me. So I try to present things in multiple different ways. Only time I talk about valve disease is what's going on in valve disease. And so stenosis. The easiest way I know of explaining that is you have a garden hose, right? So this is my garden hose, water's flowing out at a nice flow at a steady rate. What happens when I put my thumb over that? Yeah, it sprays. I'm increasing the pressure, right? So I'm increasing the pressure. Am I getting as much flow out of that? The pressure is increased, but is as much water coming out of that as it was? No. So the same thing is going on in a valve. When a valve is stenosed and it's not opening all the way, it's like the thumb over the cardiac output. The pressure is increased going across it, but I'm not getting nearly as much output. So that's all. So that's why we have to see patients with valve disease and that have severe output issues. Essentially, that's what's going on. You have that reduction in cardiac output because of the valve disease. Case study, and then we'll take a break and or lunch or snacks, or it really just depends on what kind of snacks Glenn's got. If I'm eating through that.
When you're eating it.
Yeah. Yeah. So 23-year-old male admitted to the hospital for malignant hypertension. He has diabetes mellitus from the age of 8. He fails to take his insulin. He fails to take his antihypertensive medications. 1 week before the admission, he started having vomiting. He's tired. He had blurred vision. 12 hours before going to the hospital, he had a loss in speech. Blood pressure is 220 over 140. No orthostatic hypertension or hypotensions. He has edema in the lower extremities. When they examine his ophthalmic evaluation, he's got hemorrhages in the hemorrhages in the retina. He's hyperkalemic. He's got low bicarbonate level. His creatinine is 20. He's got protein in his urine. He's got red blood cells in the urine as well. Couple things. It's going in kidney failure. So couple things. Protein in the urine, atypical. We are not supposed to have protein in the urine. Absolutely not. There's no instances. There's a problem with the renal system if there's protein in the urine. There can be some trauma from blood cells in the urine, but that's atypical as well. Creatinine, that's high. That's really high. 20, that's a problem.
Is that coming from familial?
Yes. Yes, that is absolutely where that's coming from. This is his heart. I didn't realize I left that drawn on there yesterday, but does that look normal? No. He's got cardiomegalia by all means. He's got left ventricular hypertrophy. He's deep QRSs. Patients obviously in a hypertensive crisis, hypertensive emergency, you're right, kidney failure. And the reason I bring all this together is to show what's actually going on with multiple organs. So he's having damage to his heart. He's had cardiomyopathy. He's going to heart failure. He's having cerebrovascular disease. You see the microvascular issues in the eyes, retinopathy. So cardiovascular disease, diabetes, hypertension. That's all developed into this massive perfect storm. The other catch is this guy's got going for him. He's African American and he's overweight. He doesn't have a good prognosis. He's going to need kidney, dialysis and a transplant. One of the things I didn't mention for that is why African Americans are predisposed to hypertension and cardiovascular disease. And I walked around this part yesterday, and I just trying to find the best way to describe it without saying that that African Americans are. The word that kept coming to my mind was not a positive one, and we're predisposed genetically, they're predisposed to cardiovascular disease and heart disease and hypertension because they have a excess of angiotensin 2 in their system. Just that the bodies just generally produce more. They also are predisposed to endothelial cell dysfunction. Remember, we talked about endothelial cells rupturing, causing plaque. So dysfunction, they're already genetically predisposed to this. That's why it's a risk factor for them, regardless of everything else. So I see more African Americans with heart attacks and strokes and diabetes, and they progress much quicker. I didn't realize I put that in there. Coming back to this real quick. You picked up on the protein in the urine and the blood in the urine. So, protein does come in to the renal system, but protein is not supposed to actually be filtered into the tubules. Protein is supposed to leave the renal system and come out, leave the arterial, wow, that's just terrible. That didn't work. That didn't look right. But protein is supposed to stay in the vascular system. When we have protein crossing the through the glomerular filtration system, indicates we have a problem with those podocytes in the renal in the glomerulus. So that means there's damage to the glomerulus. Same thing for the hematuria. It could be an upper or a lower renal problem too, to have the blood cells in the urine. So we don't necessarily know that, but most likely it is a problem with the glomerulus, having the red blood cells in there. So protein in urine is not normal. Blood or white blood cells or red blood cells in the urine, not normal. White blood cells could be like, UTI too, though. So FYI. But these patients are hyperkalemic because they're not able to balance out the system anymore. We've already had damage to the kidneys. Creatinine is 20, and the other side of all that where are they going with that? I don't remember where I was going with that, but maybe his GFR. His GFR is going to be dramatically reduced because his creatinine is already in 20 at that point. So this guy's got a long his only option is going to be dialysis and maybe a kidney transplant. We're seeing a lot of cool things happening with artificial kidney. Matter of fact, I saw Medtronic's artificial pancreas was approved by the FDA this week. Wow. Yeah, that's cool. I mean, to me, that's the kind of stuff that's like, that's cool to me. I mean, that's awesome. I'm sure it's going to be, which is funny. I was reading the article, so I look up what's on HBO's Repo Man as I'm reading the article. If you've seen that movie where they're repoing the artificial organs. Oh yeah, it's like a company that sells artificial organs. Don't make your payment, they're going to come take them from you. Yeah.
I do got a question about the kidneys that you were talking about.
Okay.
If we do have a patient like our dialysis patients who are in kidney failure, are all these patients anemic?
Are they anemic?
Am I expecting to be anemic?
Eventually, yes. Because erythropoietin is produced.
They need EPO shots?
They may. Most of them will actually ultimately be transfused because the kidneys can't process erythropoietin because they're damaged. If they're depends on how progressed. I mean, if they're in end-stage, if they're on dialysis, they're in end-stage renal failure. So they're ultimately going to go through cycles of transfusion and then depletion, and anemia, transfusion, depletion. But they may get EPO shots, but more likely they're going to be getting packed red cells. But yeah, that's absolutely because the kidneys can't produce the erythropoietin. So, yeah. Real quick definitions of shock, and I added this one last night. I kind of forgot I did that. This is what happens when you drink beer and work on slides. So know what the different terms mean when you're talking about pressures. CVP, RA pressure, same thing. Know what, so no relation to hypovolemic shock. Know that a patient with high pulmonary, a patient with a high system shock, either like left-sided and a high pulmonary wedge pressure. If they have a low, low wedge pressure, they have a right-sided MI. If they have high wedge pressure, they could have pulmonary edema. As far as their wedge pressures, you're looking at if they have congestion, they have mild congestion, it's 20, moderate congestion, 30. These are not numbers you have to commit to memory, just kind of things to give you an idea. The higher the number, the more severe the pulmonary congestion is in those, just kind of FYI. I'm not going to cover imaging methods, x-rays, ultrasounds. There was something I wanted to say about kidneys, and I don't remember what the hell it was, but I'm sure it'll come to me. I'm going to pause this right here, and we're going to discuss whether we're going to take, because somebody's watching. Yeah, so my goal is to be out of here just because I got stuff to do tonight in Pinehurst.
That's what I was telling you. Every time you guys need to leave, I have to work tonight also.
All right, so there's a video with this, but I couldn't get it to work yesterday. I'm going to try to get one to work today, but we'll see how it goes. I don't know how many times I've said we need to know what that formula is. It keeps repeating itself for some reason. That might be important, but I'm not going to beat that part to death. But if we run into an instance where we're asking what the balloon pump's purpose is, it's to reduce afterload and to increase coronary blood flow. That is the textbook definition of what a balloon pump does. Right. It is used for, as an attorney would say, we use all the following, including but not limited to angina, so before, during, or after open heart surgery, before, during, or after high-risk angioplasty, emergency situations, including MI, congestive heart failure, waiting for a donor period for heart transplant. And we're seeing it fall out of favor a little bit, and I'll explain why once we get to the end. But that doesn't mean we stop using it. It's still a very, it's a time-tested tool. It's been around for the better part of 2.5 decades. So, when we look at how it works, the concept hasn't changed. So, when we place a balloon pump, it's always placed femoral. There's no other option for us, any other option for us to place. So we place it femorally. It inflates during diastole. It deflates during systole. It's nothing you don't already know. So we advance it until it sits just below the aortic arch. We want it below the subclavian arteries and the arch itself. So then we want it above the renal arteries. Why? Why do we want it above the renal arteries? Right. Don't want to include the renal arteries. Right. Exactly. The balloon pump attaches to, or the catheter attaches to the balloon pump. The machine pumps helium into the balloon, causing it to inflate and deflate at specific times, and reduces the workload. And the reason we use helium is because helium is the smallest of the noble gases, of the non-toxic gases. So helium, I can move helium a lot faster than I can move nitrogen. Right. So that's why we use helium. That's why I'm saying you can't go as fast as the machine can, because even though we're inflating and deflating, we're not going to be able to inflate or deflate it at that speed. Right. So. Oh shit! Apparently done. No. The balloon's inflated during diastole, so in sync with the closure of the aortic valve, and the blood in the aortic arch, so above the level of the balloon, it's pushed backwards and provide an increased coronary blood flow, because that's during diastole. So we're using it to increase that pressure to perfuse the myocardial through the coronary arteries. And it's deflated just before systole. It helps with decrease the afterload because it creates a void in that space. So as it deflates, think of it as when you're a kid and you're in the swimming pool and you push your hand through the water, and what creates a vacuum behind it. Same concept, but creates that vacuum behind it. We're just moving the blood out of the way. Common problems. Bleeding at the insertion site. Very common problem. These patients are on heparin. Most of the time they're on heparin. They could be on like the bilirubin or pyrothioate, something like that. Most of the time it's heparin. Those are just newer, less risk medications, antiplatelet medications. But if you have a hematoma or bleeding at the insertion site, just 4x4 pressure at the insertion site. It's not something where it's not, unless it's just absolutely gushing blood, you're not going to have to put a lot of pressure. It's just a little bit of pressure. Because the catheter's in the artery holding pressure. The only way that you're going to have a massive amount of bleeding is if it gets removed or if something were to really dislodge and tear it. But it shouldn't be an issue. Migration of the catheter to block blood flow of the renal arteries. That's why we block our urine output. We see all of a sudden we have a drop in our urine output. It's been 100 mLs an hour, and we've been in transport for an hour, and then we've only produced 30, 40 mLs. We're still producing urine, but why has it dropped off so much? Right. What's changed?
So is it common for somebody to have 100 milliliters of urine output an hour? Really?
Yeah.
That's a lot.
Yeah. If they're perfusing and if they're hydrated. Most likely somebody with a balloon pump's not going to have 100 mLs output because they're not perfusing well. Right. Loss of pulses in the extremity. If the iliacs are, let me use this color because otherwise I'm going to show them. So the iliac arteries, as the balloon pump catheter goes up, they're narrowing the iliac, so that didn't get accounted for. When that balloon catheter goes up there, the catheter is going up this way, we could absolutely cause an occlusion in the iliacs. So loss of pulses. Generally, this is going to happen before we ever get the patient. We're going to figure that out. But always check your pulses before you ever take your patient. Usually they're going to be marked. If they're not marked, mark them, get a Doppler, find out where they are. If there's no circulation or poor circulation, or you see signs of it, then it might have to be removed. I mean, obviously, we're not removing it, but we have certainly had to remove balloon pumps and move them to the other side. All right, let's see if I can find this video because it is a good video. It didn't link over, so. Well, tell you what, it's on my computer. Just give me half a second. I'll just move it over, right? I know it's on this computer. Just a matter of why I didn't do that yesterday. Where those couldn't find it.
This video is designed to be a line item demonstration of the balloon pump operational competency for the purpose of satisfying the minimum requirements for its use during transport. For additional education on counter pulsation physiology and overall basics, Teleflex has an outstanding educational website.
They do.
The Survival Flight Aero AutoCAD two-way intra-aortic balloon pump competency can be found in the clinical education folder of our Survival Flight shared drive.
So I steal what I can steal.
The balloon is inflated during the diastolic or resting phase of the cardiac cycle. This allows blood to flow retrograde in order to increase coronary artery perfusion. Subsequently, the balloon is deflated during ventricular systole to allow for a reduction in afterload or resistance that the left ventricle must pump against. The actions of the balloon inflation and deflation are aimed at reducing oxygen demand and improving the rhythm. When verifying an appropriate position by chest x-ray, the radial pig tip should be approximately 2 centimeters distal to the left subclavian artery or at the second or third intercostal space. This is about to the level of the first thoracic vertebrae or T1. Alternatively, look at the carina. The balloon tip should be approximately 2 centimeters above this. Check the left radial pulse for strength and quality to ensure that the balloon is not occluding the left subclavian artery. Likewise, assess for adequate urine output to ensure that the balloon isn't including the renal artery. At the base of the pump, locate the power switch. Determine helium level by the electronic gauge in the lower right-hand corner of the screen. When indicated helium level gets below 100 psi, it is a good idea to change tanks. Verify that you have access to a spare tank. There is usually one in the utility bag attached to the pump. Find the door cover for the helium tank and open. Ensure that the isolation valve for the helium tank is closed. Turn the nut on the tank collar counterclockwise to loosen. Remove the tank collar and inspect the small gasket sealing the helium inlet. Insert the replacement tank into the collar. Line up the pin connections on the tank and collar. Tighten the collar nut by turning clockwise. Open the valve on the helium tank, power up the pump, and assess helium level. All right, so what we're going to do is we are going to zero the arterial. So you have 3 arterial pressure select indicators. One is the monitor, which you can actually slave this to the bedside monitor, which we never. The transducer, which we use about 9 times out of 10. And a fiber optic option, which we will rarely use because our pumps don't have that capability. So what I'm going to do is I'm going to select the transducer. And then automatically it'll come down here and it'll have us zero the transducer. So we'll go off to the patient, on the air, you'll get a flat line, then we'll go to transducer 0. It'll tell us that we're 0, and then we'll go back onto the patient and we'll be set. All right, helium's attached, ECG electrodes are on the patient, taped down. We've zeroed our arterial line and we've attached it to the insertion side of the catheter. And we've got our trigger established. Find the helium line to the pump that you are changing from. For our purposes, this will be a McKay, formerly known as Datascope model. Next, Locate the balloon insertion site and identify the arterial line transducer connection, the fiber optic cable, and the helium supply to the balloon. Of importance to note is that recently, our transport teams have noticed an increase in the number of capped connections to the transducer site. As we are currently unable to utilize a McKay fiber optic balloon on our Aero device, we need to have a transduced arterial line in order to effectively utilize our pump during transport. Therefore, if the capped connection is spotted off, you will have to transduce a radial arterial line connected to our Aero AutoCat 2-wave pump. Next, select the appropriate balloon pump adapter, either a 30, 40, or 50 milliliter size. We use the 40 milliliter balloon adapter for the vast majority of our patients. Now, remove the helium line from the McKay pump, cut the end of the blue helium adapter line, and connect the two. This can easily be done with a blue Christmas tree adapter that we keep in our Survivor Flight stock. One issue that we have recently discovered is ineffective augmentation due to too much helium line being added. While it facilitates ease of transport, the dead space in the line limits augmentation. Therefore, it is now recommended that we either shorten the line or remove altogether from the collar of the balloon adapter on our Aero device. It is recommended that you let the pump performance guide your decision during transport with respect to how much line to have. We're in autopilot mode, and so now we're ready to start initiation of chemical pulsation. So all we have to do is hit on, and you notice that this down here is the balloon inflation waveform. You've got the arterial pressure waveform with an augmented arterial pressure. It's kind of off the R wave or the ECG lead. Because the solid pressure of 98, diastolic of 68, with an augmented pressure of 127. We're working pretty good. So if we were needing to change right now, we're in a 1-to-1 timing assist ratio. We can change it to a 1-to-2. And that's how we would establish whether or not we need to change our timing at all. We can't do it off a 1-to-1. You can do 1-to-4, or even a 1-to-8. So if we have a patient on, say, another device like an Impella and a balloon pump, the Impella is going to be doing all the work. The balloon pump's not going to be doing much, but we don't want the balloon to clot inside the aorta, so we just want it to inflate and deflate every once in a while, so we keep it at a 1-to-8 ratio. We will briefly review the fiber optics system on the AutoCat 2-wave. However, the only time that we would use this in transport is if we had a pump with a fiber optic module and we're taking a, so we look needs of the patient. So typically, in an autopilot mode, the balloon pump can time to the needs of the patient way better than we can in manual mode. Even in the presence of arrhythmias, this balloon pump can time way better than we could manually. But in case we decide that we are smarter than the balloon pump for some reason, we can go to an operator mode. So if we go to an operator mode, we'll just come down here and hit operator, and now we're in operator mode, and the balloon inflation and deflation marker is here, and we can time this off the, actually what we'll do is we'll time it off the arterial pressure waveform if we're doing this manually. So what we're gonna do,
Nobody does that.
is I'm gonna stick it in a 1-to-2 assist ratio so I can actually see patients' inherent arterial pressure waveform as well as the augmented arterial pressure waveform. You see up here this white line is going to correlate with inflation and deflation. So we want to start inflation at the dichrotic notch, which indicates the closure of the aortic valve. And before the next arterial pressure pulse beat, we want that deflation to initiate. So we don't want to have the patient, we don't want the balloon inflated while the left ventricle is trying to contract. So we can adjust inflation and deflation. Inflation's on the left, deflation's on the right. So what I'm going to do is I'm going to set up my inflation a little bit earlier to establish timing with the dichrotic notch. And so it's going to take a couple of cycles for me to get it right with the dichrotic notch. But again, I'm looking at the white line here. And so it looks like I'm about at the dichrotic notch, and it looks like I've got really good augmentation. I've got a decent blood pressure, 106/65 with an augmented pressure of 137. And my deflation, I'm going to try to prolong that deflation a little bit and do it right before the next systolic beat, if I can, to optimize my inflation and deflation. Now what I'm going to do is I'm going to show you really quick dangerous timing errors. So the dangerous timing errors for this is early inflation and late deflation.
What is the augmented blood pressure?
So the augmented pressure is the pressure that we're causing with the balloon pump.
Gotcha.
So I get into timing errors in a few minutes, but I just wanted to. Like to use that just to illustrate the difference. So troubleshooting. One of the biggest things is batteries. Runs off an internal battery. It's supposed to have 2 hours of battery, but how long does our cardiac monitor last? And it's supposed to have an hour of battery. So always make sure I have that power cord. Make sure your inverter works, especially if it's going to be a long transport. If it's popping down the street, that's one thing, but transport one from Nash to UNC. I want to make sure it plugs in. So the EKG lead should always be hooked up. Take the EKG leads down, depending on what your trigger is. We generally trigger on pressure when we're transporting because EKG, you have a lot of artifact. It'll work, but the pressure waveform is not gonna vary as much as the EKG waveform will. So I was trying to just taping the EKG leads down that are on the balloon pump itself. Usually they're on heparin, so they have a higher risk of bleeding. So just checking that groin site regularly. Also, making sure that the arterial line from the groin, or if it's hooked up to a different arterial line, needs to be monitored as well. And make sure that the transducers, even with the plebistatic access, and zeroed once we get the patient situated. Helium leak, always have a backup helium container because inevitably it's gonna leak, something's gonna happen. So I always say be very, very prepared. Head of the bed, less than 30 degrees. Again, it's got they got 14 French catheter coming out of their groin. Actually, I think it's 14. Been on the side of the balloon, or the side of the pump, but it's a big catheter coming out of their leg. It can only be in standby mode for 20 minutes. So longer than that produces the risk of blood clots. So just FYI, we talk about the failure. Do balloon pumps fail? Absolutely, they do. Is it really common? No, it's not as common as one would think, but we need to know what to do if it does. So cycling that every 5 minutes, just inflating and deflating the balloon, just make sure that happens. The other thing is I just want to make sure you have a rupture of the balloon. if you get rust-colored flakes, means that the balloon is ruptured. That's a test question. It'll be up here. I guarantee it. See rust-colored flakes, the balloon's ruptured. You know how many times that's happened?
Probably hardly ever.
Yeah. I read a peer-reviewed article last year because we were having a discussion of with our medical director about, well, how often has it actually happened? A peer-reviewed article, it's like about 17 instances of balloon pumps rupturing.
Really?
We put in balloon pumps a lot. I mean, I'm curious to know the statistics on how many balloon pumps are put in a year nationwide, and 17 in like 20 years they've found them ruptured. So hardly ever, but I guarantee if you take the CCP, the FPC, or the CFRN, that'll be a test question. Guarantee it.
I know it's a little off subject, but like just recently, we're just starting to get where we're having like LVAD patients. So in this area, we never really had LVAD patients like that.
And so the LVADs have been proliferated so much because you're right, we're just seeing them in more patients. And one is we're doing a better job keeping patients alive. And then at smaller regional hospitals, we're doing a better job with getting patients to LVAD centers. Before, these patients would never make it there because they'd be that sick. Or we weren't able to, the technology just wasn't there where we could proliferate it as much. Now they're doing these things every day. You wouldn't see in Duke.
And it's awesome, man. It's awesome to see it, but at the same time, it's a good thing to see, but without proper training for your average person on an EMS truck, it's not going to be any good. LVAD doesn't have a pulse with it, right?
No, most of them do not have a pulse.
Right. So
There are some that have pulses, but those are generally the older ones.
Right.
And you can have.
You don't think you can do a CPR on unresponsive person.
Yeah. So, generally, unless we tell folks the best piece of information is going to be that patient's family member. They know more about that thing than you would ever imagine to know.
And I'm taking this is way off. Like this is way off. Like let's say squirrel moment. But we had a code a while back. I worked for cardiac with, and the whole patient family thing is amazing because this crew was running the code, and nobody had asked the family anything about this. Just them. And I come to find out, he just got home from the hospital, and he was diagnosed with hypoglycemia. They put him on oral potassium. His last measurement was 2.8, and they sent him home with oral potassium. Right. So the crew that was running the code thought that they saw VTAC, so instead of going to lidocaine, they decided to push altogether 450 milligrams of amiodarone on this guy. So, needless to say, I kind of got into an argument because I told him at this point, if he had a chance, you just killed it all the way. I mean, really, you just gave a potassium channel blocker to a hypocalemic patient. What was your thought process on that?
But they don't know.
No, their whole thing was, well, it was VTAC.
We follow the protocol.
Right, amio was VTAC. Well, not necessarily.
Follow the protocol. We had this discussion last night.
And it was the whole family.
Yeah.
Family history led you to it. I had to ask.
Yeah, we had this discussion last night. Where's the clinical decision making? Let's just squirrel a little bit. You have patients that has an inferior MI. You have these services that are punishing people for, or absolutely don't give nitro because they might have a right side of it. Right. So what about doing? Question: what about having to do the right side 12 lead? It's like I was told by his boss, you're going to get in trouble. Stay in your lane.
See, people are stuck in the old ways, man. They're not trying to progress with the
And I said, the hell with that. I'm going to start a fluid bolus and give nitro and see what happens. That's what I do. Even if I do it right, I'm going to do a right side 12 lead. But I'm still, unless it's a right RV infarct for sure, I'm still going to start a fluid bolus and give them nitro.
I mean, at the end of the day, we do carry a positive ion tropes. So
yeah, that's.
So we can always come back.
I can always fix it.
Right.
The problem is when you fail to recognize it, that's the bigger problem. It's like, so they're giving albuterol to everybody. That's every respiratory difficulty is like, so
Yeah.
patients, the ones that are good and they're dyspneic, albuterol. That seems like a good idea. Like, it's dumbing it down to the lowest common denominator.
Yeah. They just don't give me I call them
You're right. You're absolutely right. When transporting a balloon pump, make sure it's strapped down. Make sure everything's secured. So position everything so you can see it. Make sure your inverter works.
Yeah, Max is scheduled for
If
the day before you.
the in a fixed wing aircraft, make sure that we are cautious about the balloon when they need to autofill the balloon during takeoff and landing, because again, as the pressure changes, so that balloon will expand. So then descent, same, it'll contract. Just FYI. Arterial line. So want to make sure that is zeroed and level with the fluidostatic access. If not, your number is going to be altered. Tubing should be free of air bubbles. We talked about that a little bit earlier.
Matt just had pressure back infusers up on the screen right there while he was talking. Gary's getting us a couple.
Oh, cool.
Gary's getting a couple.
Okay.
All right.
So,
Max says hey.
so that, and this is not kind of beating the dead horse. What I talked about dichrotic notch earlier. The dichrotic notch is a meaning twice beating or twice two humps. So you look for should have a waveform and then a second smaller hump. That's that dichrotic notch. And this is an older Datascope balloon pump. We have it. We use it for training. We have a newer one that does everything push button manually. Obviously, this is just like everything else with all the older stuff. You can get in blood and all kinds of stuff in these to be functioned, but technology hasn't changed just that much. Just the human interface itself. During transport, timing is really just dependent. I mean, if you have awesome, you've got great EKG, that's great, but aortic, so timing with the A line is probably the best route. And if you have to enter, like they talked about in that video, if you have to enter a time delay based on the inflation or deflation, you can certainly do that. As far as adjusting that, and each balloon pump is just a little bit different as far as adjusting that time delay. Datascope is probably the largest. Well, I guess they're Maquette now, but they're probably the largest manufacturer of balloon pumps by all means. A couple other companies do it, but theirs is probably the most widely used. It's a real simple process. It's just a push button, and it just moves that bar just like that video showed you to. This is what the balloon waveform looks like. See, A is your filling balloon baseline pressure. B is your inflation. C is your peak overshoot of the pressure. D is your plateau pressure, and then E is your deflation, and then F is your vacuum, where it sucks down and creates that vacuum on that undershoot. So timing, generally we say timing should be at 1-to-1, unless there's a reason, patient's tachycardic. They have a heart rate of 130 at 1-to-1, we could actually cause more problems than not. 130 may be borderline there, so we generally say, if we have to change the timing, cut it down to 1-to-2, but if they've been tolerating 1-to-1, great. If they're at 1-to-2, great. So
1-to-1, 1-to-2.
So one inflation for every beat. So one inflation and deflation for every beat.
I get you, so when you say 1 to 2, like in the tachycardia.
Tachycardia is one inflation for every 2 beats. So every other beat, and then 3, depending on what, if a patient is, if patient condition is very dependent. And like they said, they have they had a balloon pump and an impella placed. And impella placed, we'll talk about the impella in just a minute, but then the impellas don't all work. There's no point having the balloon. There's no reason to have the balloon pump there too. They had it maxed out at 1 to 8, so every 8 beats, we just inflate and deflate, just to do it, just so it didn't clot. All right, so this is the EKG, and then your inflation cycle. The line down here at the bottom is one complete cardiac cycle. Your B is the unassisted diastolic pressure. C is the unassisted systolic pressure. And you have your balloon inflation, and this is your diastolic augmentation. So the pressure's higher because the balloon's inflated, right? And then you have this low overshoot down here. The low overshoot is your reduced end diastolic pressure. So that's your negative overshoot. And then your F is your reduced systolic pressure, because as you inflate and deflate, as we push out, the pressure doesn't have to be as high because we've reduced that afterload in an effort to try to make the heart work less. So typical, beautiful waveform. I duplicated the slide. This is where some of the frequency, the trigger, how you're setting the trigger, setting the pressure sources. And again, each one is just a little bit different. So this is an old model that we use for training. And then this is manual fill. If it's not functioning, we can manually fill it. Just like takeoff and landing, we'll turn the balloon pump off. We'll manually fill and manually deflate. Cardiac arrest. Generally try to have it switched over to a pressure, switch over to pressure trigger. We'll leave it in place, do CPR, it'll inflate and deflate just with chest compression. So let it run. So it'll synchronize as it needs to be. We can defib with it in place, no problems, just touch the machine. Not saying that the current will go through defibbing, but you could, especially if the damn thing's not plugged in, if it's not grounded, if it's on battery power, there's a lot likelihood that it'll go through that. So normal augmentation, and this is what I'm talking about. Augmentation all is I'm augmenting the diastolic pressure, so I'm increasing the diastolic pressure because we're trying to perfuse the coronary arteries. So this is non-augmented systolic pressure. First, inflation of the diastolic, balloon deflates, and then your reduced systolic pressure. So that's decreasing the overall workload of the heart. It's normal augmentation. When early inflation, it's inflation prior to the aortic valve closing. What would be a problem with that?
It would create blockage from my code wrong.
Give me 1 second, let me answer this. After there at 8 o'clock. Yep. Not a problem. All right, thank you. Okay. Yeah, I know. Yeah. I'm really poor me dealing with it for 10 days.
Right.
So, like you said, yeah, if we're inflating that prior to the aortic valve closing, we're creating a backflow pressure for one thing. We're also creating a problem with increasing that workload on the heart. So this is probably the most dangerous and the most significant timing error we can have. On the waveform, you'll see an inflation prior to the dicrotic notch. You'll see diastolic augmentation that'll encroach into systole. You'll see increased myocardial oxygen demand, aortic regurg, increase in afterload, just generally bad effects. If you were to happen to see a item ever be tested by IBSCC or the nursing side, this timing errors, this is one. This FPC, CCP, this timing error is absolutely tested. I put a normal pressure, normal waveform up top. You have, I always consider early timing sharp, free sharp waveforms. You lose the V or lose the nice notch at the bottom, but see your augmentation, everything's almost even across the board. Late inflation, not as bad as early inflation. So inflation after the dichrotic notch, you lose the V shape altogether. So it really just doesn't perfuse coronary arteries as well. So this slurs this V. Again, you can tell how this wouldn't be as bad an issue, but it easily fixed. So early deflation, you have a sharp drop after the diastolic augmentation. You have aortic in diastolic pressure, and is the same for both assisted and unassisted. You may see a rise in the assisted systolic pressure. So in this instance, we see poor perfusion of coronary arteries, see retrograde flow, we see suboptimal afterload reduction, and increased myocardial oxygen demand. So your two worst case scenarios are early deflation, early inflation. Probably the worst is early inflation. And this is, we're talking about the diastolic. Your two end diastolics are almost even. Look, these are easy test questions right here. Waveforms, knowing the waveforms, especially that early inflation. Late deflation, so you see a rise in the systolic waveform is delayed. Diastolic augmentation wave is widened. You have no reduction in afterload, maybe increase the afterload by impeding LV ejection. And it does increase myocardial oxygen demand, but well, hell, I thought I had a picture of it, but I guess I must have deleted that. I'll find one before we get done today. Why? Well, hell, we've already talked about it. If it stops inflating, then we have to manually do it, right? Yep. If there's no power, battery fails, we have to manually do it. If we run out of helium, what do we have to do? We got to do that, or manually inflate it. One or the other. If you forgot to bring another bottle, then shame on you. But but if we if we run out altogether, there. Patient stops making urine. That's a problem that we're not going to be able to address right off.
Yeah, I was gonna say, what do we do?
In flight, we just need to notify, in flight or en route, we need to notify them, hey, especially, again, if you're a puddle hop, if you're a one-stop shop here to a facility that's just a few minutes away, you're not going to notice that. Right. But if I'm getting, been on the road an hour and we haven't had any urine output, we see a margin drop, right, I'm going to let them know because they're going to have to reposition that.
So what do we do if we still have like a hour, 2 hour transport?
That's not
stop.
not going to be something we can reposition.
So they just have to deal with the renal damage that's going to come along with it.
We're not going to be able to reposition a flight because we're not ready to do that too.
I would want to.
We do it on fluoro, so we'll do a bedside fluoro. When we do it, so I know some physicians that'll do it with echo, but I would be very very cautious of that. For loose pulses in legs, same thing. Hey, I started, we had pulses, now we don't. They need to know that because they're going to have to do an intervention when they get there. So they don't want to call it, you know, they're going to want to have their cardiologist ready to deal with that.
So in other words, these two findings are definitely something that you need to know and report.
Yep.
There's nothing we can do about it.
Correct. It has to be something that gets fixed. So before I click that, I don't know if you have you ever heard the Impella?
I have, I'm not familiar with it.
All right, so the Impella is a percutaneous in place notepad. It's temporary, it's approved for up to 7 days, and we will go in through the femoral artery, we'll go through the subclavian artery, and we'll place it in the left ventricle, and I'll show you what it does, but it's pretty cool. And this is why I say balloon pumps are kind of falling out of favor, because we're doing more of these catches. They're a lot more expensive than a balloon pump. A balloon pump catheter is like $1,800. This thing's $36,000.
Right.
So, but one of the things about this is it has actually been proven to improve left ventricular function.
Really?
So it actually heals the heart. The short little video from Impella, but I thought it was pretty cool. Maybe. Or not. All right. I do know. Actually, I did think I had to get that from their website yesterday.
The Impella system is placed percutaneously through the femoral artery using a monorail technique and a standard pigtail. It is advanced across the aortic valve and into the left ventricle. Impella pulls blood from the left ventricle and expels it into the aorta, actively unloading the left ventricle. This active unloading of the left ventricle increases end organ perfusion and protects the kidneys from acute injury. Impella is the only percutaneous heart pump providing hemodynamic support to enable heart recovery. Impella is indicated for protected PCI and cardiogenic shock in the setting of AMI and post-cardiotomy. Impella provides hemodynamic stability during angioplasty and stent placement by maintaining mean arterial pressure. By providing hemodynamic stability, Impella may allow for more complete revascularization in a single session, which has been shown to decrease the rate of major adverse cardiac and cerebrovascular events. A randomized controlled trial and additional studies have demonstrated a reduction in peri and post-procedural adverse events. Impella promotes myocardial recovery by stabilizing hemodynamics, unloading the left ventricle, and perfusing the coronaries and end organs.
So it actually can, it does what an LVAD is doing. It's taking the blood from the left ventricle and injecting it into the aorta, taking the workload off the heart. The balloon pump lessens the workload for the heart, but the heart still has to function itself. So a patient with a right or left-sided heart failure or left-sided, big LAD and I, and they have reduced ejection fraction.
Welcome back. Today we're going to be covering hemodynamic monitoring.
That got me yesterday too. With a reduced ejection fraction, the Impella is going to do all the work and let the heart recover. What do you do when you're sick? You stay at home and you rest, right? Same concept. We're letting the heart rest and recover. We had a patient who's a 34-year-old or 30, he was not much older than me at that time, so like 35-year-old, somewhere in there, male, or not much younger than me. So I think he was, anyways, comes in, he's got triple vessel disease, he's had an active MI, he's got a blockage in the right, circ, LAD. our goal was we're going to fix the right environmental stent, give him enough time, place the impella LVAD to transplant. That was the goal. Don't know why didn't end up going the transplant route for whatever reason. I mean, I know the guy didn't smoke. He's genetics. It's just terrible genetics. And 3 days after the LVAD, his EF went from like 36-ish and actually improved. We're like 44. I'm like, oh, well, that's pretty good. I mean, that's a marked improvement, all because of the impella. So we ended up going back and fixing everything and placing stents everywhere. But all because the guy ended up having the impella in place for a total of like 17 days. They're approved for 7 days, but they have said they've had people up to 40, 45, 46 days. I know I had one of my coworkers, she came from Richmond, Virginia, and they had one in place. So we have 36 days. Like it is impressive. They have a version that does the right side of the heart too. This is only, if a patient has a big right side of the eye, then that version that goes to the left ventricle wouldn't do any good because it's not the left side that we need to worry about.
Going in the wrong house.
Right, going in the wrong house. But we can do a right-sided impella, same concept. We're helping the right side heal. A lot of money involved in this. But I got to look at it this way. It's the only thing that we can do outside of a heart transplant that's going to heal the heart. And for patients that don't meet, criteria.
They're at number 300 on the list.
Yeah. I mean, we do one of these a week.
Well,
I mean, that's a lot.
is almost every major hospital in the state doing it?
I would say every major hospital in the state is doing them. I don't know about every PCI center.
Sure.
They should be,
But Mission, somebody in Charlotte, somebody in Greensboro.
absolutely. This company is done a remarkable job. And the interesting thing about it, you encounter them because we can transport them, and I'll show you what the console looks like for these things. So this is what the device looks like itself. Now, let's go. They do have an app for that. So, well, it's funny you mentioned that because, so, I'm trying to find a console here. All right, let me just. So this is what the console looks like. This console is about this big.
Like an LP12.
Yeah, it's a little bit bigger than an LP12, but the console is very user-friendly. And if I have problems, it's got troubleshooting built into it. That balloon pump doesn't have troubleshooting built into it. They've done a remarkable job with technology and to do this. And it can migrate just like anything else can. It can migrate back across the valve because problem. This right here tells us that it's positioned. It tells us that what the flow is working with 3.5 liters a minute. A lot of flow. It's not a full. They do have a version that goes up to 5 for bigger patients, but it actually adjusts the flow. It doesn't have to. We don't have to say that. Oh, I need to reduce the flow. It's actually doing these calculations all the time. So the device itself has been really remarkable as far as the technology.
So with this in place, my bypass and my aortic valve can't close all the way.
Nope. So the other catch though is it doesn't need to.
Right.
So the aortic valve, but the bicuspid is not going to affect it. It's only going in ventricle. Like one of the ventricles coming into the aorta. But it's not. It doesn't need to close because it's not working. I mean, it is closed on top of it, but it's not going to actually close the way a simulator valve works. But
So it doesn't affect my coronary perfusion as far as.
Nope.
Okay.
so it is basically think of it as a pump from the left ventricle expelling into the aorta, and it is a remarkable tool. I mean, I try not to sound like a cheerleader for them because let unmute that.
But hey, you're,
I mean, it's
is, you're not being paid directly.
no, I'm not being paid directly. I mean, yeah, I have stock in the company because I believe in the product.
Yeah.
But I mean, because it's a remarkable product. When I said, holy cow, this is the only thing like this right now that we're doing that's really helping. I say really helping. It's really helping. Yeah, this is a remarkable piece of technology. The other thing this company has done is they have a 24/7, 365 clinical call center. So I'm going to fly to 10,000 feet and all of a sudden I'm getting an alarm and I have a problem and I can't solve it. Somebody's going to answer the phone and walk me through this process. I was in transport between Pinehurst and UNC and I had a problem and I couldn't resolve it. And it was a cycle error that was going on with the device. It said kept getting suction. I say, I could, usually we can resolve that. So I said, okay, well, here's what you do. We're going to cycle this down just like we are when we're about to pull it. So we cycled it down from auto to P8 to 7 to 6 to 5 to 4 to, and we cycled it all the way down. He said, okay, now you're 3, leave it there. 2 minutes. 2 minutes went by. He said, okay, go up. He walked me back up. Took about 10 minutes on the phone with me. Went back, working fine. So I mean, there's nobody I can call to do that with a balloon pump. Not that I have a problem. It's not as technical. It's not as big an issue. But the fact that they committed to making this kind of support system,
Right.
Pretty cool. I mean, I think it's. Yeah, I mean that's the whole thing. So let's see. We had a discussion yesterday about what adverse events are. Acute renal dysfunction, same concept. If we are acute, because we're going through the aorta. So valvular injury, usually that's on insertion. Cardiogenic shock, stroke, death, hemolysis, limb ischemia, infarction. That's pretty much generally that. If we're putting this in, we're not putting these in everybody.
Right.
This is somebody who's sick who absolutely needs support that's going to die. But just the fact of the technology themselves, and we have the RP here. So this is the RP. We place it through the venous system. We're going up through the venous system. See, we already have an LP in place, or a CP in place. It's going through the atria, through the ventricle, into the pulmonary artery, and we're taking blood from the venous side, and we're unloading it into the pulmonary artery. So we're taking the workload off of the right side of the heart.
So is it like a stylet or something on the end of the impediment? The actual look is up there?
No, that's a pigtail
Okay.
catheter that we use pigtail catheter to thread in place.
And it stays in there the whole time?
Pigtail comes out.
I was wondering if that would cause some irritation,
Yeah.
especially sitting in the ventricle like that.
Yeah. So what I say that pigtail comes out. This right here stays in
That's what I'm
place.
talking about.
Yeah. No. But we thread that over a pigtail catheter. So I do
So
that.
that doesn't ever cause the ventricle to become irritated?
I'm sure it may, but it's not going to be not to throw arrhythmias there.
Okay.
It looks a lot bigger than it actually is too.
I just didn't know if it would maybe have the same etiology like a swan's cat backing over to the right.
It could. So it hypothetically could. We could see ventricular irritation. We do see that sometimes, but usually we resolve that prior to placement. And we're looking at these things on we look at both fluoroscopy and we routinely ultrasound to make sure to check the placement. The other thing about this, if I can find the a sheath, picture of the sheath itself. So the sheath actually has it tightens down and locks in place. So it should not move when we're transporting. Should not. It's sutured in place. It's locked down, so it's going to hold it in place, and then it's dressed all the way down. So it should not move. But and then this is what, a lot of good pictures on here actually. But so this right here is the put where the sheath locks down on top of the device, so it should not move. But I think it's a really cool device. I think it's changing the way we treat some patients in certain instances by all means. I'm gonna take a break and use a restroom since you and I are the only ones here, or I'll share them. All right, cool. So we'll talk about heart failure, and the reason to discuss heart failure in this is because we don't do a good job in our initial education about what heart failure is and how it affects people. We know we get heart failure patients, right? And we, what is really going on with these patients or how we got here. So it's a condition in which the heart itself can't pump enough blood through the body. It doesn't mean that the heart's stopped. It doesn't mean that it's about to stop working. It doesn't mean that it's not able to, or it just means that it's not able to pump the blood in the way it should. So it can be because it can't fill with enough blood, or it can't pump with enough force, or both. It doesn't happen instantaneously. It happens, as over time, as the heart becomes weaker. It can affect the right side, it can affect the left side, it can affect both sides. Most cases involve the left side of the heart where it can't pump enough oxygenated blood to the rest of the body, where right-sided failures, it can't effectively pump the blood to the lungs, where it picks up the oxygen. So they both feed off each other. Left-sided heart failure backs up into the lungs. Right-sided heart failure backs up into the body. Left-sided heart failure will eventually lead to right-sided heart failure. The weakening causes a buildup of blood to back up into the lungs, or back up of fluid into the feet and ankles. These patients are tired, they're short of breath. Affects over 5 million people each year, or in the United States, with an additional 500,000 diagnosed for the first time. Contributes to well over 300,000 deaths now. This is a little bit older data, but has now progressed even further than that. We're in the South. We have our fair share of heart failure patients. Synonymously, congestive heart failure, so, with also left-sided heart failure, right-sided heart failure, systolic, diastolic heart failure, goes a number of different ways. So major causes divided into underlying disease causes, coronary artery disease, hypertensive heart disease, congenital heart disease, acute MIs, pulmonary embolism. Precipitating causes could be anemia, infection, so bacterial endocarditis, pulmonary embolism, hypervolemia, nutritional deficiencies, and we say precipitating causes, something that increases the workload of the ventricles and basically causing a decompensation, some exacerbation of that heart failure condition, leads to increased workload. Ventricular failure, it can be described as diastolic or systolic. And systolic is the most common thing we see. It results in the inability of the heart to pump the blood. And it's basically a defect in the ventricles and able to contract and eject the blood. So it loses the ability to generate enough pressure to eject it through the aorta. And with systolic heart failure, we see an ejection fraction that has been compromised. Yeah, caused by, can be caused by MI, hypertension, cardiomyopathy, mechanical abnormalities, valvular heart disease. One of the interesting things, valvular heart disease, we do see a lot of younger people that actually have valvular heart disease and heart failure from it. It can affect young and old. Most of the time it's older folks by all means, but it can affect young people. Diastolic failure is the inability of the ventricles to fill during diastole. Decreased filling results in decreased stroke volume, and so there's normal in diastolic failure is normal systolic function. You know what I mean? Stroke volume. So if I guess it's just this PowerPoint. I can't draw up. I tried to do this yesterday too. So I thought it was just something I did with the computer, but well, I really messed that up too. I'm going the wrong way.
Yeah.
Anyways, so diastolic failure, we have a reduced ejection, or we have a reduced output, but we don't have a reduced ejection fraction because we get, you know, if you got 100 mLs in a ventricle, I'm just using even number, and in systolic failure, I'm only able to eject 40, a 40% ejection fraction. In diastolic failure, I may be able to get 50 in there, but I'm ejecting 40.
Right.
So my fraction is normal. I just don't have enough of it. Diastolic failure characterizes high filling pressures. It results in venous engorgement in both the pulmonary and systemic vasculature. It results in LV hypertrophy, chronic systemic hypertension, aortic stenosis, or hypertrophic cardiomyopathy. So we see that kind of progress and build upon itself. Diastolic and systolic failure mixed origin. You see in different disease states. Again, ultimately, somebody with systolic failure may end up with diastolic failure as well. Patients often have extremely poor ejection fractions and diastolic and systolic failure together because we can't fill it and we can't eject it. So these are very, very progressive patients. Congestive heart failure, left side, we talk about backing up into the lungs and the pulmonary veins. Right-sided backs up into the right atrium and the venous circulation. See splenomegaly, hepatomegaly, vascular congestion. So generally just fluid back up everywhere. It can be caused by a whole host of other diseases that cause damage to the heart and increasing the workload. Okay, fine, stop texting me. Number one cause, coronary artery disease. It's including MIs, angina. Most common underlying cause, people who have heart attacks are obviously at a higher risk for heart failure. Diabetes, high blood pressure, smoking, add that on there. Other causes, cardiomyopathy, which is disease of the heart valve disease, abnormal arrhythmias, congenital heart defects. That's usually is their younger patients. And we have children that have heart failure. We don't really think about it in the same way, but they have different symptoms. We treat them differently, but we can have children who have it. I have a friend, his paramedic. He's younger than me, just hit 30 this year. Ended up having valvular disease, another heart failure. He's been out of work now. Actually ran with such a poor ejection fraction he couldn't do anything. And did rehab, got him to where he's strong enough to stand the surgery, the valve replaced. He's been out of work over a year now. In this whole process, he had an open heart surgery. And he's still in cardiac rehab, developing a strain, but heart failure because of valvular disease. So, other conditions, you have cancer, radiation, chemo, thyroid disorders, too much or too little thyroid hormone circulating the body can contribute to heart failure. HIV, AIDS, alcohol, cocaine, smoking. Could be vaping in 5 years after we have the research. It's just not there yet.
Oh yeah, I totally agree. I don't know. They say that right now they try to say that vaping is
It's
so
better
much
than
a
smoking.
cigarette. I don't believe
There's actually, I saw an article the other day about the effects are going to be, the preliminary are just as bad, but we're still early in the data.
That's just it. Yeah, all those data support cigarettes, but you don't have any bad data to really support these.
Yeah, we just don't have the data yet, and that's
It's coming. It's coming. The only difference I've noticed with a vape as opposed to a cigarette is that's the acid reflux isn't as bad as opposed to with the actual cigarette.
Because it's not irritating the mucosa nearly as much.
Right. And I don't have the whole tar.
Yeah.
Like I do with my actual tobacco.
The biggest thing, respiratory wise, that's what Christina had this discussion yesterday. It atomizes the nicotine so small that you think of it's actually penetrating into the pulmonary vasculature, plugging the alveoli.
Mm-hmm.
Where the cigarettes, what smoke is crossing into, some of it's crossing in, but it wasn't nearly as small, so it's not nearly causing that problem. So I think we're going to see a whole host of obstructive lung diseases.
Oh yes.
It's just we just don't have the data yet. But
It's crazy because a lot of people who did not smoke cigarettes before started vaping because it's cool, it tasted good.
it's
And actually, man, I've read a few articles also that says that if you switch from cigarettes to vaping and then you go from vaping to back to cigarettes, you actually smoke more cigarettes when you leave from vaping.
because you're getting
Higher nicotine.
higher nicotine with that.
Yep.
Yeah, absolutely. And
So concentrated.
so we talked about the so the nicotine that's in that's actually causing an increase in your stimulation of your nicotine receptors in your body. So you see, you know where I'm going. I'm not going down that road. So heart failure patients that are over 65, that is probably the number one reason, or it is the number one reason for hospital visits in this age group. Hospital readmissions, CHF is absolutely it. African Americans are more likely to have heart failure and suffer more severely. Why do you think that is?
I know you said something about genetics earlier, but I do realize that a lot of African Americans are higher risk for high blood pressure, diabetes, kidney disease.
Yes, all of the above. The genetics related to the endothelial dysfunction, to the increase in the circulating of angiotensin II, to diabetes, so kidney disease, all of this plays a factor together. So absolutely.
That's why I tell a lot of my African American patients that I pick up, especially in this area, is a lot of them just, you know how it is when you get these areas where just the income's not here with your average person, and they don't take care of themselves, and they walk around with blood pressures of 230 over 110, and their sugar will be 320, and it's like, look, well, I don't mean to be ugly, but
Boy,
African American with those, you're gonna be on dialysis in a year.
That's the other thing I want to mention about kidneys. I remember when I said talking about the filtration of kidneys, and glucose is another thing in the urine which is not supposed to be there, right? And we see the patient with, even if we can't get a blood glucoses, or we don't have a blood glucose, or we're reading the chart saying they have glucose in their urine, well, off the bat we know it's over 300.
Right, you get in ketones in the urine.
Yeah, we already know it's that high. So African Americans have heart failure and get worse quicker because of all these problems. They're more frequent. They visit hospitals more frequently for it. They die quicker from it because of all these things. Plus, education, culture, access to healthcare. And everyone thinks like that. Everyone, or I say everyone. People say that's bullshit. There's not. there's not less access to healthcare for them. I said, no, there is less access to healthcare for them because of, and I'm not going on a socioeconomic thing, but culture-wise, there's less encouragement to have primary preventative healthcare and follow up with their practitioners. It doesn't happen. It's culture. And then you have diet and exercise, diet too goes with that.
And especially in this area, man, I know it's somewhere where it takes 6 years. It's nothing to take them to the hospital. At that initial visit at the ED, they get their blood pressure under control. They go home. Oh, I feel better. I'm good.
I'm gonna stop taking my medicine. I'm gonna go have some Popeyes fried chicken.
Yep. I had a guy I picked up recently. He sent me a friend request on Facebook, which I'm not accepting. So I don't do the whole patient provider thing.
Yeah,
it's a little weird. So, but his thing was, I picked him up and his blood pressure was high. And his whole thing was, I'm supposed to be on medicine, but I don't believe in medicines. I'm more of an herbal person. And I said, okay, well, how's that working out for you? Pretty good. I said, really? Because your blood pressure's 190 over 120.
Yeah.
It seems like it's working pretty good. So you keep playing. You might not remember it next time I come over here.
Yeah, absolutely.
He's using something old.
3 of them?
3 guys, two different companies. In fact, I was already putting money back in my account. So my PayPal, so I have cards canceled. But he told me there's a way to use a PayPal app, go to Walmart, they'll generate you a barcode. You can get $500 cash out of your PayPal account.
Oh, that's good.
So I'll buy a prepaid gift card with that, or a prepaid debit card.
Just get one that doesn't have a fee to it.
Yeah.
Or if they give you $500, go to the credit union. That thing only costs $1.
You're talking about the credit
Yeah.
union instead of $5 at Walmart.
Right. So
That's the plan.
those are like the ones at Walmart charge you every time you use it.
Yeah.
So I don't know if the credit unions do that or not.
It
I
doesn't.
don't think they do that. But anyways, men have an absolute higher rate for heart failure than women, but in actual numbers, there's more women that actually have heart failure because we're dumb. Yeah, we die sooner, we die quicker. They live a lot longer than us. So
Tell me this. Last time I went to my PCP, PA, she gives me a number and says, this is your heart failure risk number. And she said, you're on the very low side. What is that test? How does she know that?
like a risk score?
Yeah.
I don't know off the top of my head.
Okay. Well, I didn't ask the question at the time, and it's bugged me every damn since.
I don't know that off the top of my head.
Okay.
I mean, I'm assuming it's based off of clinical it's got to be off of data that she's gathered, but what score they're using.
I thought, she's out of her damn mind.
Yeah.
I'll ask her next one, sir.
And I don't have an answer for you too. So, but I just don't know what it is.
Okay.
Children with congenital defects, children with patent foraminal valleys, anything shunting defects, or absolutely other congenital heart defects or valve or blood vessels near the heart that don't develop correctly or at risk for heart failure. This can weaken the heart muscle and eventually cause that. We don't treat them the same. We don't. They don't have the same symptoms, so it's not really what we see. Fatigue is probably the earliest manifestation for patients with heart failure that we see. They get tired real easy. They, everyday tasks wear them out. Dyspnea, most commonly what we see. Patients, I'm short of breath. I have trouble. I get that. Not just I'm tired. I actually can't get enough air. So this could be due to pulmonary pressures, pulmonary hypertension, edema in the alveoli, tachycardia. This is probably the first symptom and nobody really recognizes it. The rapid heartbeat is the first compensatory mechanism. The body needs oxygen. So enough epinephrine to increase the heart rate. There we go. We just don't. By the time we're seeing them, they're already short of breath and tired. Maybe have edema in the legs, abdominal cavity, liver, nocturia. When a person lays down at night, they have all this edema other places, and they lay down, body is taking that interstitial fluid and it's coming back into the circulatory system, and we have more circulating blood volume. Well, that increased renal blood flow causes an increase of diuresis. So patients that have to get up, pee, get up, pee, get up, pee. So they made these patients like, man, I just had to get up and pee 5, 6, 7 times a night. So increase in frequency of urination. Hold on 1 second. Let me respond back to this text message real quick. I think I didn't respond the first time. You would have gotten the clue, right? Yeah, I get it. I'm sorry. I hate doing that.
Okay.
I'm having to deal with it.
Oh.
You may see patients with dusky, cool skin, cool to the touch from diaphoresis. Behavioral changes. Cerebral circulation is changed in these patients. So they are always the absolute most pleasant people on the face of the planet, right? This is because we've decreased cardiac output, so they may be angry, they're restless, confusion, they've decreased attention span, memory. They're just not happy people. These people are generally angry. I say the angry, that's the wrong description. These people have behavioral changes from where they normally were. But CHF patients are generally angrier than most of the other ones.
Yeah, I had noticed, I've had a coworker before, he had a CHF. It was actually when I picked up 2 weeks prior. Real bad CHF, for most time he is a patient in the 60s, sats in the 60s. But trying to put a CPAP on the patient, and she was very agitated from it, right? So he gave her Versed to calm her down, and had a bagger. Now, I'm not a big fan of it. A lot of times I'll let them hold the CPAP on for a second. If they'll eat, because a lot of people tolerate better if they can hold it as opposed to me trying to smash it in the face. I'm just not a big fan of Versed, Ativan, anything like that.
Well,
severe respiratory patient.
Yeah, and so one of the things about Versed is, CHF patient already, we're 65 years plus.
All right.
So we're already going to need to cut how much we're giving them anyways. And it depends on, if I'm in the field and that patient is, I'm going to be a lot more cautious about doing that. But I'm going to pick up a patient to take them to another facility, and the hospital, they're like, oh, the patient's not been able to tolerate a CPAP. I'm like, dude, their sats are in the 60s. This is not stable to me. So that patient, I'm in a much more controlled environment. I will give that patient some Versed as soon as I reach them. A little bit. I don't want to kill her. I don't want to knock the respiratory drive out, but her sat's already in the 60s. She's hypoxic up here. I need her to be able to tolerate the CPAP, but maintain her own airway.
Now, what do you think about CPAP with inline?
With an inline neb? Yeah, absolutely. It's if it's indicated, but it's hard to depends on what kind of CPAP you'll have. You'll have the oxygen powered.
Screws right to the side of your portal.
Screws right. Yeah. So they make a version of that has the inline net built right into it, and I think it works great. But if you have to have your own T adapter, make your own, makes it a little more complicated.
It always comes with it, but I guess it worries me a little bit because I don't want my patient to flash.
Right.
And if I got you on people 5 and I go to inline you, and that's just not enough pressure, I hate them to flash. So should I increase my peak if I do it inline? So if I got you at 5 and you're sustained at 5, and I decide to go inline, should I increase your peak to 7.5, or should I leave you at 5?
I would generally do it at 7.5. 7.5. But I don't necessarily. I mean, the risk of them caught, having them, and the risk is there, obviously, having that flash needle. But the likelihood of that coming from one nebulizer treatment is probably not going to be there. And the risk is there, obviously, but I would be, it would behoove us to, well, so we talked about earlier, monitor your patient, right?
Right.
You don't want to treat and release. And essentially, that's the whole. We talk about the cookbook medic, just letting it, just going through the main protocol and doing that. But if I think there'd be benefit from it, then yeah, I'll absolutely do it in inline neb. Patients with weight changes, and it may be hard to see because they'll see weight gain, they'll have weight loss, they'll have just based on the fluid fluctuations. Until they get the fluid off, we may not really see how much weight change they have. So frequently they're end up having like anorexia, but we just don't know because they got all this extra fluid.
Maybe you guys are based on weight, like 1 kilo equals 1 pound. I'm sorry, 1 kilo equals 1 liter of fluid extra weight on your body. Kind of like a dialysis does.
I'm sure they do, but I don't. Maybe we do daily weights on folks, so we'll see how much weight changes we are. But
so like we were talking earlier, urine output. If I know my patient has a normal 100 milliliters an hour urine output, if I notice it drops down to 30, and over the last 12 hours, my patient has added an extra 2 kilograms of weight. So now, like, if you correlate it and say, well, you may have 2 liters extra fluid on you.
Yeah, absolutely. But the catch is, we have to be able to trend it more than anything.
Right.
So be able to trend it plus strict INOs to be able to know exactly how much is going in and exactly how much is coming out. So we're able to balance that. And then everything that we're doing is for most parts off ideal body weight, not actual body weight. Because if a patient's got 30 extra pounds of fluid, well, the fluid, there's no medication exchange, there's no exchange taking place there. It's not doing us any good. It's just like patient that's, that's 700 pounds, or I'd say that's a little excessive, but if you have a lipophilic medication, we run the issue of toxicity issues if we're based off weight at that point. So, yes, long story short, yes, trending it and watching with our eyes and O's of the patients. In the transport environment, no, it's not going to be an issue. But this is in a long-term starting care. These patients are going to be admitted for several days. We're restricting fluid intake. We're monitoring outputs. Yeah, we absolutely can figure it out. Figuring out pound for pound or kilo for kilo how much fluid is there, probably not, because interstitial fluid, depending on what the concentration is, coming up with exactly. But yeah, roughly saying, well, we know this is much in, we know this is much has come out, weight loss has been X. We can make a rough estimate, or pretty accurate rough estimate. That's okay. Complications.
If you only have one, you're doing good.
Yeah, I mean, I've had like 4 or 5. I've been doing pretty good today.
You've been on it today.
Yeah. Pleural effusions, arrhythmias, LV thrombus, hepatomegaly is a big one because of the venous congestion. The New York Heart Association guidelines for classifying people as CHF. So this is based on tolerance to physical activity. I don't necessarily want you to know that the difference between them all, just know one's no physical limitation of activity. 4 is severe limitations of activity. So 1 being the least, 4 being the worst. Drug therapies a little bit. This is the last part of this thing. We see patients on drug therapies, and we're not going to be nothing that we're going to do in the pre-hospital environment or even the transport environment doesn't make anything. But patients will be on ACE inhibitors. Probably the primary start of this is ACE inhibitors for both systolic and diastolic. You know, it's lisinopril, captopril, enalapril. There's a couple others, but your ACE inhibitors are the first line treatments for these. Diuretics, loop diuretics, potassium sparing diuretics, aldosterone inhibitors. Most of these got to be careful electrolyte imbalances. I mean, loop Lasix. We talk about it being a potent diuretic. I mean, it's a real potent diuretic. I mean, talk about part of it, not reducing losing urine, we're excreting potassium, excreting sodium, we cause hypomagnesemia, hyper, I don't know which one we can cause, hypercalcemia. So we're losing massive electrolytes. So that's one of the reasons we decided to get away from routinely using Lasix in pre-hospital, is because we can cause bigger problems, more problems than we have.
Yeah, I know in the agency I work at, the only time you give Lasix, you have to call for an order to give it, or it has to be like 30-minute greater transport.
Yeah, so that's one of the reasons, because it's such a potent diuretic. We can cause electrolyte imbalances, and so, but it works. It's inotropes, because they increase cardiac output, and let's do thing from DIG to dopamine, dobutamine. The beauty of dobutamine is you get all the depressing effects, and we have no actual increase on the cardiac workload. So we get the beta effects, but we don't have to get the nasty alpha effects out of that. Calcium channel blockers, obviously, we may routinely transport patients on beta blockers, on nitrates. Whether it be nipride or nitro, things like that. So we very well routinely transport CHF patients. Nipride's probably is a very popular one, but it's also a very short one, because we can actually have toxicity related to nipride. Yeah, nipride. Beta blockers, carvedilol, Betalol. And diet, we discussed that already, and I'm not going to get into the nursing diagnosis stuff that I do for them at home when I go over this stuff. It cuts out about, do what?
Concept map.
So, I'm cutting out lunch. I'm done. Is that a problem?
Not for me.
Okay.